see if I can find my video. Good afternoon, everybody, and welcome to the CALBHB annual meeting. Thank you to everybody that's shown up on a Friday afternoon. We have several folks here in Marina del Rey, which is right next to Los Angeles. And I'll take a look to see how many people we have online. 18 people. We're a small group. We're a small, cozy group today. So hopefully we'll get some good discussion in. We have a packed agenda, and I'm going to go ahead and turn it over first to our president, Bill Stewart.
Well, I'd like to welcome everyone, and I'm extremely excited about the presentations today and just gathering again with all the familiar faces and great knowledge there. So I want to welcome everyone and appreciate all that everyone's doing to continue to improve behavioral health in California. So I'll turn it back over to Teresa.
Great, thank you. For the agenda today, we have first, it will be the California Behavioral Health Planning Council, and we'll get an update from them. Then the Commission for Behavioral Health. Then we'll have a presentation on psychiatric advance directives. And then we have a panel discussion on integrated vocational behavioral health services. And then since this is our annual meeting, we're required by our bylaws to have our governing board meeting in person. So we have a different agenda for that governing board meeting. It will be an hour long from 3:30 to 4:30, and you're all welcome to join that. And then at 5:30, we'll open up, no, I'm sorry, at 4:30, we'll open up for issue-based discussion. It looks like I have that wrong on this agenda. But at 4:30, after the governing board meeting, then we'll listen to whatever you want to share with us in terms of challenges, successes for behavioral health, or if there are things resources that you need, or support you need for your boards or commissions. We'll get an update on that. So let's go around the room now, and we'll allow you all to introduce yourself. Let us know your name and your county, and if there's another mental or behavioral health organization that you're related to, if you want to identify that as well.
Start off because I forgot to mention the county I represent. So I'm Bill Stewart from San Diego County, and I'm also on the California Behavioral Health Planning Council.
Thank you, Bill. I'm Stacy Dalglish from the Los Angeles Behavioral Health Commission, and the governing board of CALBHB. I'm not standing on. I would fall over because there's so much stuff around my feet. So my name is Patricia Wenzel. I am on the Sacramento County Mental Health Board. Soon we will be convening a behavioral health commission, but the work to do that is still in progress.
Good afternoon. I'm Jamie Hatchett. I'm Jamie Hatchett. I'm the CALBHB governing board member, and I'm also chair for Sonoma County Behavioral Health.
Oops.
Hello, everybody. My name is Benny Benavides. I'm from Ventura County on the advisory board. I'm also part of the executive board for CALBHB.
Christine Hoffman, I'm on the Napa County Behavioral Health Board and Secretary Treasurer of CALBHB.
Hi, Janet Frank. I'm not on any board. I am a member of the California Commission on Aging.
Hi, good afternoon. I'm Allie Mink. I'm the chair for the Behavioral Health Commission of San Bernardino County. Been on the board for about since 2023. And I am also the vice president for NAMI San Bernardino area, and also involved with NAMI California. Hi, Liz Seguera, also part of the Planning Council and also work with the California Alliance.
I'm John Black, and I'm your Director, CEO, Operational Chairperson, and Delivery Board for Peer Recovery Art Project in Stanislaus County.
I'm Dr. Erin Frankel. I'm an LMFT out of San Bernardino County, and I also sit on the California. Behavioral Health Planning Council. There you go.
I'm Steve McNally. I'm on the Orange County Behavioral Health Advisory Board.
Barbara Wilson from Los Angeles County, not on any board.
Barbara's on the LARCA board. All right. Thank you, everybody. Let me zoom out on myself. I'm pretty large right now. Okay, let's go online now. Let's start with Gregory.
Thank you. My name is Gregory Farron. I'm on the Behavioral Health Board for Sonoma County. I'm their representative to CalBHBC, and I'm also on a separate Measure O board, a board with $32 million a year that comes in from local tax to be spent on mental health, homelessness, and addiction services.
Thank you, Gregory. Let's go next to Truth.
My name is Truth Snow, and I work with Sutter Yuba Behavioral Health.
Great, thank you. I need to pull up my participant list. Okay, let's go next to Amy.
Hi, everybody. I'm Amy Dietz, and I'm from Placer County Behavioral Health Advisory Board.
Welcome. Linda Smith.
Hi, I'm Linda. I'm from Orange County and I sit on the Behavioral Health Advisory Board.
Welcome. Annie.
Good afternoon, everyone. My name is Annie Tu Henrich, a member of the CalBHC Governing Board, also member of the Stanislaus County Behavioral Board, and in addition, I'm also the president of the Stanislaus Asian American Community Resource. We advocate for the API community. Thank you.
Thanks, Annie. Let's go next to Antonio.
Hello, good afternoon. This is Antonio Rivas. I'm part of the Santa Cruz County Mental Health Advisory Board, and also I'm a board member for the California Senior Legislature.
Welcome. And let's go next to Arlene.
Yes, I'm Arlene Weissman. I'm with the Calaveras County Behavioral Health Advisory Board, and I'm having trouble with my video.
Okay. It looks like, I wonder if my settings are off too. I'm not seeing videos. Let's go next to Ashley.
Hi, my name is Ashley C. Cho. I'm with Shasta County. I'm the MHSA coordinator.
Welcome. And then let's go to Jonathan.
Hello, Jonathan Raven, CalBHBC Advisory Board, and also a member of Yolo County's local behavioral health board.
Great, welcome. And then let's go to Barry Johnson.
Yes, good afternoon, everybody. Barry Johnson. I'm Deputy Director for Transitions Mental Health Association. We're a nonprofit providing a variety of behavioral health services in San Luis Obispo and northern Santa Barbara counties.
Great. Thanks for joining us. Becky?
Hello, I'm Becky Jordan. I'm from Lassen County. I'm a board member of Lassen County Behavioral Health Advisory Board.
Great, thank you. And I see C33412. I'll move to Dakota.
I'm Dakota Westlake, and I am part of the San Bernardino County Behavioral Health Commission, District 3.
Good to see you. Let's go to Daniel.
Hi, everyone. Good afternoon. My name is Daniel Collin. I am staff to the Behavioral Health Board of Contra Costa County.
Great. Thanks for joining us.
This is C33412, by the way.
Okay.
Sorry.
You want to identify yourself?
Yeah, my name is Ted Lopez, and I'm a member of the Placer County Behavioral Health Advisory Board.
Welcome. Giselle?
Hi, good afternoon, everyone. I'm Giselle Tamayo. I'm with King's Partnership, a nonprofit based in Kings County. And we're also funded by our Kings County Behavioral Health.
Great. Kimberly?
Hi, everybody. Kimberly DeSerpa. I'm a second district supervisor for Santa Cruz County and also on the Mental Health Commission, the Behavioral Health Commission in our county. Thank you. And a licensed clinical social worker.
Okay, thanks. Thanks for joining us. Linda Smith? Did we already get, or go ahead, Linda.
You already did me.
Oh, I did. Okay. Wait, now I'm going alphabetical. Manuel?
My name is Manuel, and I form part of the CALBHB staff, and I'm happy to be here with you all today.
Hi. Mark Donegan?
Mark Donegan, Mendocino County Behavioral Health Advisory Board.
Michael Bryant?
Michael Bryant, I'm the chair this year of Kern County Behavioral Health Board.
Great. Nicole Bayless?
Nicole Bayless, I am the board secretary for the Shasta County Mental Health, Alcohol, and Drug Advisory Board.
Good to see you again. Rachel?
Hello, Rachel Ibarra. I'm the program manager within Shasta County Behavioral Health that supports both Nicole as the secretary of the Mental Health, Drug, and Alcohol Advisory Board and Ashley C. Chow as our MHSA coordinator.
Okay. Susan Fleming?
Hello, I am a certified divorce coach and soon to be appointed to Sutter Yuba Behavioral Health Advisory Board.
Great. Thank you for joining us. Sylvia?
Hi, it's Sylvia Garcia, and I'm from Ventura County Behavioral Health Advisory Board.
Welcome.
Thank you.
And Travis?
I'm Travis Lyon. I'm the MHSA coordinator for Tehama County.
And Truth. Did we get her already? Okay. All right, let's move on to our speaker. Jenny, do you want to come over this way?
All right, can you all hear me well online?
I think that, yeah, I think they can.
Hi, everybody. Thanks for having me with you again today. I don't think I was able to join you last time, but I am trying to come at least once a year to still connect with you all. For a while, I was coming to most of them for a little bit. Staff will be coming to present on behalf of the California Behavioral Health Planning Council, and I will come at least once a year to connect with you all. So for those of you who are new, I'll just do a real quick introduction about the council. I know many of you are very familiar with us, but sometimes there are people online who have not heard of the council. So the California Behavioral Health Planning Council is a 40-member advisory body to the Department of Healthcare Services, to the Health and Human Service Agency, and the legislature. We have 40 volunteer members from across the state. They represent persons with lived experience, family members, professional providers, and consumer-related advocates. We get together 4 times a year for our big meetings. Today was the end of our week-long series of meetings. Many of our council members also do work in between the meetings through their committees. We have committees that are focused around our areas of priority, which are patients' rights, performance outcomes committee, legislation and public policy, workforce and employment, housing and homelessness, and the systems and Medicaid committee. And so we met this week starting on Tuesday. We have committee meetings, and then Thursday afternoon and Friday we have general session. What I'm going to do is just review for you some of the highlights or high points of the different committees, the work we did this week, and then talk a little bit about general session and allow some time for you guys to ask any questions if you have any. Does anybody have questions about the council before I move forward? And is my speed okay? Sometimes I talk a little fast, but
You're fine.
okay, great. All right. So our very first committee that meets on Tuesdays is the Performance Outcomes Committee. And one of the big things that comes out of this committee that I know you all are very familiar with is the data notebook. And so something that we're really excited about actually is, you know, the last few years we had a series of 2 parts for the data notebook where we would ask you some standard questions over a 5-year period. And then we had the focus, right? And so now we're at a point where we hired a contractor to work with the council to look at and analyze those 5 years. And we actually did see some trends. They did get some really great information that is going to use to make some recommendations that we hope will be helpful to your report. And so that will be published likely in July. So a draft was presented to the committee, and they did vote on that. And there are going to be a few minor additions to that, but it will be done by the end of this month. And so then you can expect to see something in July. We will send it to Teresa when it's done, as we usually do, and then she can distribute it to you all. So it was one of the big things that happened in that group. Something else that this group has been really involved in is the Behavioral Health Transformation, Quality and Equity Advisory Committee. We have a few council members that are actually on that committee, along with Teresa, who is also on that committee. And we just heard an update about that, and the Performance Outcomes Committee did get some input and feedback that they did provide to the Quality and Equity Advisory Committee. And then the committee also accepted the 2024 data notebook overview report. And that one, which was on homelessness in the public behavioral health system. So that should be published within the next couple of months as well. So there'll be 2 reports. One, the 2024 homeless in the public behavioral health system report, and then the report on the 5-year analysis from the previous data notebooks that had the part 1. And then they talked about and kind of worked on finalizing the survey questions for the 2025 data notebook, which is going to be around wellness and recovery centers. And I'm not sure if we shared that with you last time, but that's the topic for 2025. And we've been working, Teresa provided input, I believe, and then some other organizations are providing input on that. So that's kind of a high-level overview of what happened in the Performance Outcomes Committee. Does anybody have questions about that before I move on to the next committee? All right. So patients' rights continues to track the CARE Act. And one of the things that they really focused on during this meeting was the role of the supporters. We are really interested in finding out statewide, you know, who are the supporters, you know, and then is there data being collected, which we have confirmed with CHCS that there is data being collected about that. When the report comes out in January, we'll see what that data looks like, what the information is. But we plan to continue to look into how supporters are being used statewide in the CARE Act implementation. Some pieces of legislation were discussed during this time. And what we do with the patient rights is
they have discussions about legislation and they take their recommendations to the Legislation and Public Policy Committee. And so Mady will talk about that committee. She's our staff for that committee. But during this time, they talked about SB 331, SB 367, SB 820, and SB 823. And then kind of the last things that they did is they just looked at what they're going to be doing over the next year or two. So they are updating their work plan to be focused on a lot of the new initiatives in the last few years. So there's been a lot more activity and legislation around things like care and other, pieces of legislation that the council has not always supported, particularly ones that make it easier to involuntarily put somebody into treatment. And so that committee is really looking at what do they need to focus on? Do they need to kind of add to and change the work group a little bit? Because there's been a lot of that in the last few years. So those are the types of discussions they had, and they updated their work plan accordingly. Any questions about patients' rights before?
Yeah, you mentioned. Oh, hold on a second. Oh, and we need to give you this back myself. I'm not good with mine. Gonna be a short question. Probably not valid for all the work that's going into this. You mentioned supporters and tracking supporters as one of your projects. Could you break down what you meant by supporters? Because I don't know.
Oh, so that is something that's being defined by CARE. So in the CARE Act implementation, they have a particular role that's called the supporter role. Okay. And then if you go to, there is a page for the Health and Human Service Agency has a page about CARE, and you can find all like the definitions and information there. But it's basically because there's the court's role, there's the person who fills out the paperwork to request that they be put into care, and then there's a supporter. And the
advocate, advocate.
It's like a peer advocate, but the title is supporter role. And that's part of what we want to know is who is the supporter? Is it a family member? Is it an advocate? Is it a peer? Because there's not one set individual or type of individual that can fit into that. Does that make sense?
Yes.
Okay.
I thought you were talking in a larger scope, meaning who are the supporters?
Yeah.
Individuals, the patients is not necessarily with the CARE Act. So
yeah, in this particular instance, we're talking specifically about CARE and the language that CARE uses.
Thank you.
Okay.
Do we have any other questions online or in the room?
I have a question in regards to Care Court.
Yeah. Can you tell us your name and county?
I'm Ted Lopez, and I'm a member of the Placer County Behavioral Health Advisory Board. On
D3412. Go ahead.
yeah, see, yeah, 33. That's my laptop cryptic name there. Care Court, does it have the ability to mandate treatment from a judge, and if that treatment is ignored, is there any consequence?
So typically I don't answer questions specifically about how CARE works. We just look at how, what we're interested in tracking. But Teresa's sitting next to me and she's shaking her head. So I felt comfortable on us, I think she would respond to this as well too. So I feel comfortable on us responding. But just want to make sure that, we don't speak for CARE, but no. Right. What was this question? Yep.
Right. Yeah. I think that if somebody does not voluntarily want to be part of Care Court, there's no mandate that they do that. There may be instances where it's decided that they do need to have some type of involvement with a court, but that's outside of what Care Court is. Care Court actually was put into place, and it's called the CARE Act. And they hope not to have to bring people to court at all.
Okay.
So I'm going to move on to our Housing and Homelessness Committee. Any other questions about the committee I just mentioned? Okay. So Housing and Homelessness Committee, some of what they are really interested in looking at is learning more about recovery housing in particular, because that is something that can be funded by the Behavioral Health Services Act. And as that is implemented, we really want to learn more about how that works and be able to support and make recommendations in that area. So there was a significant amount of time on the agenda to bring in persons with lived experience, and then also persons who run these programs. And so they shared with the council how they run, how they work, what's working well, what's not working well. And then council members had an opportunity to engage in conversations with them. And then in addition, something that we do in our committees and that we are trying to do more of is allow enough time for the committees to really digest the information and talk about what do we need to do next. And so that's some time was spent in this committee talking about what they need to do with this information, what recommendations do we need to make moving forward. And that was one of the really big pieces of the Housing and Homelessness Committee this time. There was also an update on the bond, the behavioral health bond Continuum Infrastructure Program, or BCHIP, round one launch ready awards. And that's just something that this committee tracks. We keep up with what's awarded and what's going on in that area. And then, and just for your information, this round is providing 3.3 billion in competitive grant funding to support the construction, acquisition, and expansion of facilities that serve individuals with mental health and substance use disorders. And there were 124 projects were funded across 214 behavioral health facilities in California, which ends up supporting a little more than 5,000 new residential inpatient treatment beds and almost 22,000 new outpatient treatment beds. And so if you didn't know when you're tracking it, last month DHCS launched round 2, unmet needs, which will provide up to 1 billion in competitive funding awards. And if you want information on that, you should be able to somewhat easily find that on the DHCS website. Questions about housing and homelessness? And actually, there's a few Housing and Homelessness Committee council members in here. If you guys have questions, I'm sure they would love to help me out as well. No questions? All right. So workforce and employment continues to be focused on BH Connect. And so they spent some time talking about that. We also heard from Karen Bakari, who is the Director of Public Policy from MHAC, who talked about the concerns that they have about Medi-Cal BH community-based provider training programs. And something she shared with us is that the program awards the training entities rather than the trainee. And if a trainee does not complete their 3-year commitment, then they are responsible for paying back the state. And so that's one of the things that is a big concern when we're trying to support peers and persons with lived experience in getting these funds so that they can be trained. And so this is something that the Workforce and Employment Committee has decided that they're going to kind of look into, to evaluate and maybe try and help find some solutions to that, because we do see that as a barrier. And the Department of Rehabilitation talked about the Employment and Recovery Program, which was a pilot. And in this program, the Substance Use Disorder Treatment Centers integrate employment services with Department of Rehabilitation Services in order to really serve persons with lived experience well. And they support them in their recovery as well as with employment services. And so this was a one-time funding program. And one of our council members, Javier Moreno, he was as a director of Aegis Treatment Centers, who was one of the pilots in this. So they just kind of shared about how that worked and what that experience was. Questions about workforce before I move on to systems? All right. So our Systems and Medicaid Committee really focused their time in this meeting on full service partnerships. That's a big piece of the behavioral health transformation, specifically the Behavioral Health Services Act. And because such a significant amount of funds is required to be spent on that, the committee really feels like we need to focus in that area. And so we had LA County come and talk about that. We also had a report from the Behavioral Health Services Act Oversight and Accountability Commission on their recent FSP report that they did to the legislature. So they provided that information to us. And then the committee, you know, had the opportunity to ask questions and kind of discuss that. And that's really important. We really need to understand and focus on the Assertive Community Treatment, or ACT, and the Forensic and Intensive Case Management Treatment, or FACT, as we go forward, because those are things that are spelled out in the legislation to be implemented. So I am going to questions about that before I move on. So I'm going to let Mady talk to you about the Legislation and Public Policy Committee, which is the only committee we haven't covered yet. So this is Mady Lowe. Mady is new-ish to the council. She joined us earlier this year, and she is our Legislation and Public Policy
Both
staff
the
person.
microphone and that, both of them next to her. You could flip that on if you want.
Yeah. So Stacy has asked for the spelling of my name. So it's spelled M-A-Y-D-Y, but I get a lot of invisible A's and double D's sometimes, and or invisible N as well. It's great to be here with you all. So just sharing a little bit about the Legislation and Public Policy Committee highlights. We heard from the Los Angeles County Department of Public Health, specifically their Substance Abuse Prevention and Control Bureau, who presented on their sponsored bill, which is AB 1037. That bill seeks to expand authorization to anyone in a position to assist with an overdose, removing the mandatory training for them and protecting them, as protecting these individuals who are administering the antagonist from any liability. And it also would require the DHCS to provide a combined application process for facilities seeking licensure for both recovery treatment and incidental medical services, and prevent treatment facilities from requiring abstinence for admission, and emphasize maintaining patient connection after a relapse. So there's a lot of moving parts to that bill that LA County has put into this one bill. The committee did vote to support the bill. And a couple other bills that the committee discussed and voted to support is SB 812 and AB 669. Also, the committee voted to oppose two bills. Both of those bills were from recommendations from the Patient Rights Committee. That is Senate Bill 331 and SB 820. We also heard from Karen Vakari from Mental Health America of California, who provided a peer perspective on AB 348, which seeks to establish presumptive eligibility for FSPs for individuals with a serious mental illness who, among other things, are transitioning from the community after 6 months or more in the state prison and county jail. The committee previously decided on a watch position, and after the presentation, they still maintained their watch position. So, yeah.
So,
Go ahead.
Go ahead.
Yeah, our next speaker is ready.
Yeah.
So I don't know how much more you have, but go ahead.
Nothing, I'm just gonna say thank you. All right, good. All right, so I just wanted to thank you all for your time and for inviting us to come. And I wanted to acknowledge some of our council members actually who are a part of your group and part of our group, and then others who came to just join. So Monica, Aaron, John, and Liz are all council members who have been here all week. And then many of you joined us yesterday and Friday, and we really appreciate it. And we love to have our friends from the Behavioral Health Board. So thank you, and I will see you again soon. Oh, and Bill, yes. Sorry, you moved over to the corner, so I lost sight of you. I apologize. Never forget you, Bill. Thank you. Thank you for your participation. No, definitely not. Thank you, and I'll see you all again soon.
Thank you so much, Jenny. We always appreciate the update.
Uh-huh.
Okay, so our next speaker is Kendra Zoller. She's the Deputy Director of Legislative Affairs for the the Commission for Behavioral Health. For those that don't follow state agencies, they used to be the Mental Health Services Oversight and Accountability Commission. Now in state law, they're the Behavioral Health Services Oversight and Accountability Commission and Commission for Behavioral Health for short. Kendra, do you want to get started?
Thank you. Good afternoon, everyone. I will say our website now is bhsoac.ca.gov, but I think if you put in the M, it still redirects you, so don't worry about that. We have a new executive director. I think it's been almost 2 months with Brenda Graylish. So we're really happy to have her. And the big change that we have right now is we've established 3 committees. And so that will change the flow of our commission meetings because the committees will really be, forming all of our grants, our advocacy contracts, taking positions on legislation, determining budget decisions. And so stakeholders are more than welcome and invited to come be a part of that process. So we're hoping to increase our community engagement that way. So our first Legislative and External Affairs Committee was, I think that was yesterday, I'm losing track. And we focused on just the overview. And what we put forward is a sort of decision-making framework for how people can submit legislative proposals to us to potentially take a position on. You can find that on our website if you click on committees. And so once we have another committee established, we'll reach out to everyone through our listserv and ask if you want the commission to consider taking a position on something, and you'll fill out this form, and then we'll meet with you and talk about it. And that's a way we're trying to have more transparency with how we take positions on things. So if you'd like to sign up for any of these committees, I would sign up for our listserv on our website. The other one that people are probably interested in is our Program Advisory Committee. And I believe they'll be meeting mid-July. They should be sending out when that date is soon. And they will be formulating our Innovation Partnership Fund that was given to us under Prop 1. It's $20 million for 5 years to do things innovative in behavioral health. And so that committee will work with the community and our partners to come up with an outline for an RFP to do this grant program. We really are hoping to have the outline done by January because the funds start in July. And since it's a time-limited grant, we're trying to I don't want to say we're working fast. We want to be diligent at how we're doing this because we don't want to lose any money. So they will be working on that, but also our other grants. We have the Behavioral Health Student Services Act related to school mental health, and then the Mental Health Wellness Act, which we are waiting not so patiently to hear if we're keeping that grant program. It was proposed to be cut by the governor's budget in the May revise. The legislature's budget proposes to keep it and also increase it by 10 million with 5 million dedicated to youth SUD. Those negotiations are ongoing, so we are waiting to find out. But if we do keep it, or if we have more money, that will be developed through our Program Advisory Committee as well. And then our other new committee is our Budget Committee. They will also be meeting in July. The date isn't set, but it should be coming out. And then the other thing I wanted to mention is we also have a client and family leadership committee and a cultural and linguistic competency committee. And they are not just made up of commissioners, but we also have public members on these. And there will be a joint listening session for both of these committees and the public on July 1st from 3 to 5. They haven't met for a while, and with this new leadership we have, we're doing this joint listening session to really come up with their goals and what they want to work on with the commission moving forward. And we're really hoping that they also are a part of developing the Innovation Partnership Fund, since they would offer some great experience for developing that. I think those are all my main updates, but I'm happy to answer any questions.
Great, thank you very much, Kendra. I appreciate it. Do we have any questions in the room? Yep, Stacy. This is Stacy Dalglish from LA County.
First of all, thank you very much. This is great to have an update, given that this is new, and it's exciting to hear the new committees that you're forming. But I just wondered, is that a rock behind you or snow? Or snow?
It's a mountain with a sun behind it.
I'm having a hard time hearing.
Oh, is I think is the microphone part of the this part working? Let's see, make sure it's on. Yeah, that should be on.
Stacy was asking, is that rock behind you or snow?
I couldn't hear that, sorry.
Can you hear me okay?
I can hear you, yeah.
Okay, I'll check our audio. Maybe our other microphones.
It might be me, I don't know.
Probably our mics. Do we have anybody online? Oh, I see Sylvia. Go ahead.
Yes, I had a question. If there are any, I know in our county we have a hard time with some of our nonprofits that are deal more with the Latino population, but are Latino run nonprofits. And a lot of them have a hard time applying for their grants because they don't know how to. So thing that hopefully, I mean, this isn't very much before January or July for some of these grants, but are there any plans to help some of these nonprofits that keep missing out on these grants because they just don't know how to apply for them?
Yeah, I mean, I'm happy to bring that up to my colleagues running the committee, but I'd encourage them to attend some of these program committee meetings and raise those concerns so they can consider that as they develop this. I know it's hard because we can't help people because, but there has to be some way to do something. And I think that's a valid thing to bring up.
So if they attended some of these committees,
exactly. That would be great.
Okay, thank you.
And I should say the Innovation Partnership Fund is for the grant can go to private, nonprofit, or public entities. So, yeah.
Hi, this is Steve McNally from Orange County. Can you hear us?
I can hear you.
I see your ear coming in, so I appreciate that. Is there an application process for the community to be on those committees?
For the CFLC and CLCC, there is, but the other three I mentioned are just commissioners.
And the other inquiring minds is they want to know what your Zoom background was.
Oh, I don't know. Everyone asked me that. I don't know. My comms office gave it to me.
It's a great look.
Find out.
All right. Well, thank you. Good to see you, and congratulations on Brenda. She's wonderful.
Yeah, she is. Thank you.
I have a question from Gregory Fearon from Sonoma County.
It's not a question, just a recommendation. The question earlier was whether or not any technical assistance could be provided to community-based agencies in your processes. I've had extensive federal technical assistance. I know that the HHS and others do provide in California technical assistance grants to agencies to go out and help them to help localities, especially aimed at those who haven't been able to get in, haven't understand the process. The state ought to think about trying to put some money into technical assistance teams that can help those apply.
Yeah, that's a good idea. I will relay that information, but again, would love to hear that raised in the committee meeting too.
Okay, I think that's all the questions. Thank you so much. Appreciate it, Kendra. Thanks for the work that you do with the commission. Really appreciate your support and ongoing connection with us.
Thank you.
Question.
Oh, there's another question. Sorry, Kendra.
Oh, no problem.
I was looking on the site and I was wondering, is there a calendar of the meetings, or is it just kind of, are they released periodically?
So they're released periodically. They will always be posted 10 days before. So they'll be posted and sent out. If you sign up on your email, you'll get that 10 days before also. But if you click on like committees, you scroll down to the bottom and you can see upcoming and past with the links, and they should have agendas and materials. And it's similar for commission meetings. There's like a menu of the last ones. So that's how it's done. But we should always be posting 10 days in advance because of Bagley Keene.
Perfect. Thank you so much.
Thank you.
All right. Well, thanks again, and we're going to move on to our next. Actually, let's take just a short break. We're a little early for our next item. Unless maybe I'm just not seeing.
I'm here.
Oh, you are there. Oh, good. We will not take a break. All right. So we have with us today Kiran Sahota. She is the president and CEO of Concepts Forward, and they are a consulting firm that has a contract with, I think they're working with several counties with a statewide collaborative innovations project. And I'm really excited to get an update on the project from her today. So I'll let you're welcome to share your screen if you want to, and get started.
Okay, so just confirming, maybe a thumbs up that everyone can see my screen.
Yes, looks
and
good.
you're just seeing the one PowerPoint, correct?
Right.
Okay.
Yes.
You would think after, I don't know, 5 years of working in my office, I would have figured this out.
I think
oh, go ahead.
Go ahead. You can get started.
Okay. And so, yes, thank you so much, Teresa. My name is Kiran Sahota, and my background actually is 25 years in county employment. I retired from a large county under MHSA. I was the administrator, and actually this year marks 10 years as part of MHSA with our counties. So now BHSA has been just a big part of my life for the past decade, and I'm really excited to talk about this project. When I retired from the county back in 2000, I was called at that time to oversee the thought of a project called Psychiatric Advance Directives. So my task was to gather counties on board to really test psychiatric advance directives in California. And so that's really what I'm here to talk to you about today. So in phase 1, 7 counties banded together, and we have a collaborative psychiatric advance directive multi-county project. And I'm going to go through. Okay. So phase 1 for us really became the build, and I'll talk to you more about what that means. But we really looked at, with the help of our 7 counties, really identifying the need for a digital platform. And so the build is the digital platform. And so I want to talk a little bit about directives in California. And many of you may not know about the differences in our directives, but we do have different directives, and each one of them acts individually, or you can have them combined. But psychiatric advance directives are the ones that we're working on our project, and they specify preferences for a mental health or substance use care, or what we call behavioral health. During a behavioral health crisis, it can include treatment preferences, medication preferences, what facilities to avoid if possible, how to de-escalate, even so much as, hey, I have children, can someone pick them up from school? It can be an instructive document with preferences only. It can be a document that has a chosen durable power of attorney, or it can be both. And that's what a lot of folks don't realize in California is both are legal. And it really is a document that transitions throughout an individual's lifespan. So think about a 19-year-old, a 21-year-old who may have their first psychotic episode. They're not looking at a medical advance directive. That's something that I have. I am a person of an older age. And for me, our next one is that medical advance directive, which really is specifying medical specific care during incapacity. You can include mental health preferences within an advanced healthcare directive, but that is really only active if you've lost capacity. And it's also typically not used through the lifespan. It is used in, you're getting medical care, you're checking into a hospital. And so then we go to the third aspect of directives in our state, and we have a POLST, which many of you may know as your pink form. My 92-year-old dad had a POLST, which was a DNR form, and really identifying how to relieve pain and suffering, and of course, your do not resuscitate. So those are the different aspects of directives, and we really chose to focus on the preference aspect of psychiatric advance directives. And why? Because what was missing in California? There's a lack of follow through in hospitals and medical professionals on a current law, and that is your 42 CFR. That has been around for decades. And a lot of hospitals will ask, oh, do you have an advance directive? In California, under advance directive includes psychiatric advance directives. So technically, all hospitals should be asking, do you have an advance directive that includes or including a psychiatric advance directive? Also under AB 1029 back in 2023, we also under probate identify that you can have a standalone PAD. There is a lack of understanding on what a PAD is and how is it useful. There's a lack of access to PADs or any directive for that matter. There's a lack of training. There's a lack of a usable registry. And as we were looking at legislation, our Secretary of State, who maintains that registry, flat out said, we have a metal file cabinet and I'm not upgrading it. Well, that doesn't help anybody that's looking to use their directive. And also understanding that there's a lack of understanding at least restrictive options, especially when we're considering conservatorship. Why are we not looking at self-determination and autonomy? So in California, we also identify that PADs are a perfect fit across the continuum of care, especially now when we look at Care Court, we look at SB 43 and Prop 1. It fits seamlessly in all aspects of our mental health system and throughout just life in general. It is great for our 90-day reach-in, which is a pilot within California. It is going to be federal. I know California is piloting it. Our assisted out, AOT, these are all items that most of you are familiar with, our AOT, our FSP, our crisis res, supportive housing. It supports inpatient and outpatient stability, our early intervention or our early psychosis, our TABE population, mobile crisis, 988, even 911 dispatchers, and also our dual diagnosis. When we looked at substance use and IDD, our platform has information on I have autism. I'm on the autism spectrum. I have a traumatic brain injury. So I am a veteran and I have PTS. And so really looking at that fit across our entire spectrum of care. So we really looked and sat down and thought, what are the benefits of having a digital pad? And really it's improved efficiency, so that real-time accessibility, improved quality of care, so utilizing a person's preferences. Why are we guessing? Why are we just making things up as we're working with individuals? Why are we not looking at their preferences? They know themselves best. Timely information for if a person has lost capacity, or timely information to help prevent the loss of capacity, de-escalating a situation. And increased care coordination, as I mentioned before. Can you imagine law enforcement being able to tell a hospital, hey, this person has a pad, or a hospital being able to say, hey, let me look at who is your preferred contact. Let's give them a call. So really that easy accessibility to preferences and immediate connection to a person's preferred contact. So 7 counties, and you'll see on my chart here, I have Alameda. Alameda is our 8th county. They're joining us in phase 2, which actually starts on July 1st of this year, as in just a couple weeks from now. Phase 1 is winding down. But our 7 counties banded together to create a collaborative project, which I'm going to tell you, in my now 30 years working with counties and in county mental health, and 10 years in MHSA world, this is by far the most collaborative project I've ever worked on. And all of these counties have banded together in the same direction, really looking at best practices and working together seamlessly. And I think that's why we have been very successful in really appropriately utilizing MHSA funding. We created a template that helped standardize the language of psychiatric advance directives. Looking at 6 or 7 templates from around the nation, having our work groups really fine-tune what that would look like, creating a facilitator training so you have that peer-to-peer interaction, creating a replicable and sustainable technology that provides individual consent on a HIPAA-compliant platform. We are looking at legislation. We looked at it last year under AB 2352, but stopped the bill, as we really want to fine-tune what our ask is. Probate already has a lot of information, but for example, we really need to work on the Secretary of State and understanding that we need a better place for a registry or access, and really looking at how we can incorporate all directives. And outcomes driven. Evaluation. That is probably one of the worst things that ever happens in MHSA. And we ended up with both RAND and BDI. So we've had a lot of evaluation just on the build. So very excited about that aspect of it as well. And I'd like to show you now what our 7 counties created. It is, I think, beautiful. When I first saw this, it brought me to tears because I'm so proud of the effort. But let me play this for you.
Psychiatric Advance Directive. My plan, my voice. Proactively create a plan for a behavioral health crisis. Getting started is easy. A pad can be created with a free account through the secure web-based platform, providing guidance along the way. The dashboard serves as a centralized hub for creating and managing pads. The first part, crisis directives, focuses on the crucial details that should be shared with professionals and others providing support during a crisis, like health history, communication preferences, and who to contact during a crisis. It also includes anyone who should not be notified. Completing each section encourages individuals and guides them to the next section. Treatment directives allows individuals to share supplemental information for professionals to consider when providing care, like instructions for medications, accommodations needed if receiving inpatient care, as well as any gender-affirming and reproductive health considerations that professionals may need to factor into treatment. The PADS platform will be available in multiple languages to ensure broader access for more communities. Once completed, it can be previewed as others will see it Individuals can see what their pad will look like when accessed by professionals and preferred contacts. They'll always have the ability to choose which professionals can access their pad. The platform makes it easy to collect signatures needed to make it a legal document. It's as simple as reviewing the pad, confirming who has access, and adding a signature in-app. As a professional, you will have the information you need to help inform decision-making, reduce liability, and enable a positive outcome for individuals like Richard. Research has shown that utilization of PADs can contribute to lower rates of recidivism in hospitals and jails. The PAD platform ensures key information about an individual's needs during a crisis is quickly accessible. Professionals can search for and find active PADs. The most important information is displayed at the top, and more details can be reviewed quickly below. You'll be able to see key information such as diagnoses, how to de-escalate, and how to communicate. PADs can be shared with an individual's preferred contact, who can provide support and advocacy on their behalf. The PADS platform helps individuals plan for behavioral health crises by voicing their treatment preferences, as well as empower advocates and professionals with information they need to offer more effective care and support. Psychiatric Advance Directives, empowering and encouraging individuals to make decisions about their well-being. Learn more at padsca.org.
So the build was evaluated by the Burton Blatt Institute, which is one of the leading institutes for disability rights. And they're also one of our evaluators for this first phase. And we created, so part of what they've evaluated, and actually the full evaluation report will be due to CBA, the Commission for Behavioral Health. My goal is to get it to them in July. And then it will be public. You can read, I think their report is actually about 137 pages. But some of the key points that we took away from the build is that the registry was created using an iterative and inclusive process that integrated feedback from multiple groups. We use peer support specialists, family members, behavioral health professionals, county employees, law enforcement, hospital staff, first responders, and other stakeholders. And I'll give the PowerPoint to Teresa so she can pass this out to you. So I'm not going to read through every single comment. You'll have that you can read later. But one of the other aspects is the platform was praised as an improvement over paper forms due to its accessibility, design, and interactive elements. Some of our stakeholder quotes was, as peers, we've done a really great job putting this together. I think we've had a voice in almost every step. Another one is, we find that the PADS technology platform developed in phase 1 has increased individuals' knowledge, understanding, and acceptance of PADS. Well, actually, I'll go into the next aspect. So now we roll into phase 2, and phase 2 is what we call a rollout. We thought we would be, having everybody have the information already on PADS, but the build took some time because we really wanted to do it right. And we spent a long time in our work groups really creating that beautiful digital website that we have now. And the product now we can fully test in phase 2. So our phase 2 goals now with our 8 counties, including Alameda, and we do have room for 7 more counties, just so you all know. I know with DHCS removing the constraints on your prudent reserves, there is funding available to join our project. It was originally innovation funding, and Prop 1 prevented some additional counties from joining because of the change in funding and the removal of innovations, but any county can join and it doesn't have to be innovation funding. So just putting that out there, because we obviously would love for this product to be in all counties, because eventually we are asking the state to take this on. So we are looking at another 4 years, and we're looking at training on how to complete the pad, training on how and who can access it. So creating MOUs and very fine-tuned relationships with law enforcement who currently doesn't have to ask. So we want to identify and work with law enforcement to find out what the best practices are, working with hospitals to understand they should be following 42 CFR and how can they incorporate that into their daily emergency department routine as well. Community-wide education, understanding the importance of PADS. And then we're going to evaluate. We're going to look at the reduced number of crises that result in incarcerations and hospitalizations by utilizing PADS, the number of PADS created, the number of PADS accessed, and the increase in care coordination. We also want to look at the positive revenue impact. A lot of counties still don't understand that peer support specialists can bill. You can bill to create a PAD. And so we really are going to be showcasing that within our next phase as well as reduced costs for hospitalization, reduced lengthy calls for service for law enforcement, and reduced unnecessary incarcerations. And then our phase 2 training, we already do a facilitator training that was created in phase 1, and the peer-to-peer facilitation has been incredible. Really just training individuals why it's important for their voice to be heard. It's just been incredible, the discussions that our peer support specialists have had. We're going to create new trainings for law enforcement and first responders, new trainings for our court systems, especially care court, probate, and conservatorship. Again, this is a least restrictive option. Training our crisis teams to provide that care coordination, how to de-escalate the situation utilizing someone's PAD, and if somebody doesn't have a PAD, how to refer them to get a PAD. And also the same with our emergency departments, really understanding their responsibility under 42 CFR, training them how to ask, how to utilize a PAD, and again, if somebody doesn't have a PAD, how to refer them to get a PAD. And with that, I'd like to open it up for questions. That was a lot. That was a 4-year project in 15 minutes, but definitely would like to open it up for questions.
Great, thank you so much. Appreciate it. Let's go into the room first. Do we have questions in the room? Okay, yeah, go ahead.
Thank you so much. That is so awesome to hear as a clinician that clients have more autonomy when it comes to their treatment and even when they're in crisis. I was wondering, is there a way to integrate the PADS, like the app, to EHR systems of major hospitals in California so that they are able to have an electronic copy of that on file if the person is admitted?
Yes, that is a great question. And so I want to be very clear. So we have a website, not an app. Apps are owned by Google and Apple, and we are protecting the data and not creating an app. So it is a standalone website. And it's I don't know how unidirectional. It means that only the individual owns their data, and they can create a PDF in the website and provide it to the hospital. So we really are looking at that. Now, there are also new laws in which EHRs are supposed to share information. And so with consent of the individual, we can absolutely connect. And that's part of what we want to do in phase 2 is find out what are best practices in hospitals. But 100%, it also has a date stamp on it so that if you download your PDF and provide it to a hospital, it'll have a date stamp on it. So if you come back to the hospital a year later, they can see, oh, this has a date stamp. Let me ask if there's an updated PAD. So 100% and the interesting thing is because this is an individual's information, it is a singular source. It is not, you cannot put a clinician's treatment notes in it. You cannot put hospital treatment notes in it. So it is not a HIPAA document like your patient records. So if you download it and you give it to the hospital, it becomes part of your patient records and becomes HIPAA protected in the hospital also.
Sorry. Oh, go ahead.
Also, as a clinician, are we able to access the website, well, when it does roll out with the client and assist them in completing that? Or is it more so just a them thing?
No, actually, we're working with our behavioral health department. Right now, we're only piloting this on our 8 counties. So ideally, when the state has it, then anybody can sit with an individual. The document is theirs, but we do encourage those conversations. And we are opening it up to this. Ultimately, a PAD, like any directive, should be someone can do it in their living room, someone can do it with their mom, someone can do it with their clinician, with a peer support specialist, with their best friend, or again by themselves. And so ultimately, this document is supposed to be as user-friendly as possible.
Awesome. Thank you so much.
Okay, we do need to wrap it up, but if we could be real quick with our questions and answers, and then
Yes, I had a quick question.
Yeah.
So, I'm from San Diego County and I'm on the Behavioral Health Advisory Board. How do we go about, because I've noticed the ones on your list were smaller than San Diego County, and I'm just curious, how do we go about promoting this? Because it sounds like a excellent option. And
Well, like I said, I would love to have more counties on board. I know that your director has actually sat in my presentations before. I have personally reached out to every single director. So you as behavioral health advisory boards can go to your behavioral health departments and say, hey, we want to do this. So I would love to expand.
And was that Dr. Bergman or Nadia, the new interim?
Oh, no, it was Luke, so Dr. Bergman.
Yes. Yes, he spoke about it during one of our meetings, but I'll bring it up with Nadia as well.
yeah, we need to move on. So real quick.
Are there witness signatures required?
Yes, that's what makes it a legal document. And a lot of our counties are working with their patient rights advocates. And so, so we will be also looking at how to make the witness signatures the easiest as possible for the individuals filling out the document.
This is JD from Solano County Chair. Thank you for your presentation. My question is, should a person, with people always moving, should they, if I'm moving from one county to another county, should I always do it from when I move to another county? Should I create another advanced directive because I move from county to county because people are always moving?
Great question. Our digital aspect follows the individual. So you would never have to redo it. And if you create the paper form, you have to make sure you hang on to that if you're not in our digital system, because that goes with you. You don't ever have to redo it. Your advanced directive, your psychiatric advanced directive is a one-time document unless you choose to update it.
Hi, this is Patricia. So I have a question based in the family perspective, which is, how reliable is this document in the face of someone saying, I've changed my mind, I'm psychotic, and I don't trust my family anymore because they're all clones. And I won't let them, I don't want them, my, whatever the label is that you have for the person who makes decisions for someone.
Ironically, we've found that individuals that fill out PADs tend to be more, I want to say cooperative when when they're in a crisis, because someone is asking them about their psychiatric advance directive, they have created it. If they absolutely deny that it exists, then law enforcement hospitals have to treat the individual as if they don't have one. But we are working with both entities to say, hey, if you pull up a PAD and someone's still not listening, please read the information, because that still may help de-escalate a situation.
I don't need a response, Stacy Dalglish. I just want to say that I am very concerned about the security of this information. So,
thank you.
Yeah. Okay, let's go to Sylvia online, and then we have another one in the room.
Yes, so who do we contact if we want to get more like not support, but just trying to convince our counties to buy into this? Who can we contact?
If you go to our website, padsca.org, padsca.org, my information is on the contact page. I do presentations every week. I'm doing presentations, even in other states right now. So I am happy to talk to anybody's boards, groups. We obviously, this is a wonderful project. And we'd love obviously for more counties to participate.
Okay, thank you. I hope we have you in our county.
Thank you.
Thanks. Okay, one last comment in the room, and then I wanted to mention we had some questions in the chat, but we'll ask you, Karen, if you could follow up on those, or I can try to connect and follow up with people. Go ahead.
Just a short question. In all of the information that you're gathering, is there a place for the individual to put in things like religious practice / preference / requirements?
Yes.
Okay.
Yes, we actually do have a whole section for that.
Thank you.
Yeah. The website itself is very detailed, but it's drop down, so it makes it very easy, or you can add a contact box. So 100% yes. And let me just answer the one billing question that was in the chat. You just have to have pads associated with your case plan. So if and then any peer support specialist or clinician can help fill out a pad, and you can bill for that.
Okay, thank you so much. You fit in a lot, and it's an exciting project. It does sound like there's some big questions around it still in the room, but also a lot of enthusiasm. So it's great to see this happening. Thank you.
Yes, thank you. And again, if anyone needs more information, please just reach out. I'm happy to give you some more.
Great. All right.
Thank you for your time.
Okay, we're going to shift gears now, and we're going to be hearing from a panel regarding vocational services that are integrated with the behavioral health services. And let me just get my screen a little better situated. Let's see if maybe it's the view that's off. Give me a moment. Okay, so I'm gonna just do a couple of opening comments myself and then turn it over to Danny Marquez. I am just so pleased with the group that's going to present today. I wanted to mention how important it is to have employment. It is a major therapeutic tool. It's an indicator of wellness, and it is required now for the upcoming Behavioral Health Services Act. It's in the requirements for Behavioral Health Services Act as well as the Behavioral Health Connect to provide what's called individual placement and support, which is a model that you'll hear about from the speakers. And it's required in all of the counties. Small counties don't have to do it to the fidelity level of reporting and tracking information as the other counties, but it is required throughout California. So let me hand it over to Danny Marquez to make some opening comments. And then we have speakers from different counties who are either providers that are community-based organizations or county employees. Danny?
Yes, thank you, Teresa. Good afternoon, everyone. Caswell would like to thank Teresa and all of you for giving us the chance to share our thoughts and experience on a key tool in expanding employment opportunities for individuals with behavioral health issues, Individual Placement and Support, or IPS. As California moves forward toward the implementation of Proposition 1 and Behavioral Health Connect, you will hear from 3 programs today that will give you excellent ideas on how IPS is implemented by public agencies and 2 community-based organizations. We hope The information we share will help you overcome any barriers and/or challenges the many California counties may see as they are planning, programming formats, funding options, and service delivery for vocational services. We also hope each of you will see how the implementation of IPS will create employment opportunities for individuals we serve in California. Our presenters today represent 3 counties, and as they each speak, I'll let them introduce myself, but we tried to get a good range of geographical areas. And so we'll begin today with a presentation from Amanda Downing from San Diego. Amanda?
Hi, everyone. I have sharing capabilities, correct?
Yes, that's
Can I hit
correct.
share? Fantastic. Hi, everyone. Good afternoon. My name is Amanda Downing. I am down here in San Diego, currently sunny despite our June gloom. I am currently the program manager for a program called TURN, formerly known as Mental Health Systems Employment Services. We are a DOR contract providing IPS support to county mental health consumers. I wanted to start us off today with just a little bit of an overview for some, an introduction for others to what is IPS. So I'm going to go ahead and share a couple of some short and simple slides. I'm not going to throw a lot of text at you. I'm going to kind of talk through what the model is and our 8 key principles that we start every IPS conversation and training with. Chris also put this in the chat, a document that refers to these, which you can also look over as a reference either during or later. So let me go ahead and share my screen. All right, does everyone see a slide that says, what is IPS?
No.
No. Let me try that one more time. How about now?
Yes. Yes. Yay.
Fantastic. And I also just want to say I am recovering my voice. I lost it entirely after coming back from vacation. I don't think it was due to the road trip with my kids in the car, but you never know. So I want to start off with just what is IPS. So as explained, the acronym stands for Individual Placement and Support. It is an evidence-based practice that comes with a fidelity scale, and it was intended and continues to support employment and education goals of those with mental health challenges. Current and past research also supports applying it to other populations, TBI, IDD, autism spectrum, and others. Any and all information about IPS you could ever want can be found at ipsworks.org. That is sort of the mothership of IPS for the IPS Learning Center. So the model really got started in the 90s. It was about the 1990s. I feel like we need to specify now. It was a transition to get job seekers out of day treatment programs and out of sheltered employment and into their communities and into competitive work. And we'll talk a little bit about how IPS defines that in a moment. It really emphasizes, like Teresa said, employment as a key component of someone's wellness and about employment being an intervention for someone's recovery and wellness, not just an outcome. So we want to be focusing on employment alongside other goals and sort of prescribing employment alongside other therapy modalities and other interventions. Research is ongoing with this model, and just want to emphasize that repeated random control trials continue on to prove the efficacy of IPS over traditional approaches. So I just want to quickly go over our 8 key principles that we start off every IPS conversation with. Apologies for those that this is a review. I think if you're around IPS enough, these sort of begin to get sort of branded on your brain. So we always talk about a focus on competitive employment. IPS really emphasizes competitive employment as being not time-limited employment, not set-aside employment, not transitional employment. It's paid at least minimum wage, and it's when I say not set aside, it's not set aside for a person with a disability. So we're looking at competitive work environments, a job that any person could apply for. It is employment that is paid for by the employer, not by monitored by an outside agency. We always talk about with programs the concept of zero exclusion. So this really talks about how we want any participant of a provider to have access to employment services, no matter where they've been or where they are today in terms of their wellness journey or their employment history. Oftentimes we hear people say that, we also hear the phrase, well, that person's not ready for work or not ready for employment. And we want to take that sentence out of people's vocabulary. We want the question to be, do they want to work, not are they ready for work? Every IPS specialist knows about benefits planning, so we know how to refer someone to a trained benefits counselor, because we want to make sure our job seekers understand how their benefits and employment can work together. We never want a job seeker to think that we're there to, put their benefits at risk or take away their benefits. We want to make sure that they understand from a trained benefits specialist how employment and their benefits can support that job seeker, and supporting someone and understanding that employment is going to get them more financially ahead than staying on benefits in the long term. We follow a rapid job search model, and I like to emphasize here that it's rapid job search, not rapid job placement. So we do get started with the job search activities right away. Sometimes this does lead to rapid placement, sometimes it doesn't if we are being more particular or we're looking for that really specific placement, that really following really specific preferences. But we do get started on the job search very quickly. We don't spend a lot of time with assessments. We don't spend a lot of time with work readiness skills or assessments. We don't ask people to achieve certain milestones before they begin their job search. We are really getting going with that job search right away. That job search is done following a systematic job development approach where IPS specialists or employment specialists are going out into the community and speaking with employers directly for the purpose of building relationships with those employers to do a good match between our job seeker and that employer. So we want to make sure that the needs are being met on both sides, that we're building relationships with employers. And the purpose of those visits with employers are not just, are you hiring? And it's not just, what is your hiring process? It's there to learn information that isn't included in a posted job description and hopefully build a strong connection so that employer sees the employment specialist as a resource. Recently, one of my staff was visiting a local nursery, and they didn't have an opening at the time during her first visit or her second visit. And before she could go back a third time, that the manager at that nursery actually called my staff person and said, hey, we just had someone quit and we would love to work with you to fill that position. So it's about kind of building that connection and being seen as a resource to help employers meet their hiring needs, at the same time making sure that we're connecting employers that are going to be the best fit for them. We do all of this while benefiting from integrated support with our mental health providers. So the employment specialist is part of the treatment team, and congratulations, treatment team members, you're part of the employment team. So we want all the employment specialists, the prescribers, therapists, case managers, peers, we want everyone to be on the same page, talking to each other, know what the goals are, supporting better engagement and better outcomes for services for our job seekers. We are also going to make sure that our job seekers know that they will be receiving job support, not just job search assistance. So job supports mean that we are there to help people get the job, and then we are there to help people keep the job. We want to make sure that we're working with family members, working with natural supports as much as we can to provide maybe supplemental support, whether it's work, school, both. We want any supporting individual that job seeker has, that when they transition from a job seeker to an employee, that they have support available beyond the meetings with the employment specialist. We want to make sure that job support plan really is individual and it is dynamic, that we are bringing in other providers support, natural support, to ideally get that job seeker now employee to a point where they don't need us anymore. I like to say employment specialists we're always trying to put ourselves out of a job, right? We don't want people to need us anymore. So we want to build in those layers of support and skills so that they can move forward past our support. What's important about IPS is that we don't set a time limit on that support. So we're not saying, okay, you get that support for 30 days, we get that support for 6 months. It's really up to that individual person to say, I don't need this support anymore. Please stop calling me. Right? Like sometimes people just are like, I don't need to talk to you anymore. And that's great. And that's what we're always hoping for. We want to make sure that person knows that it's their call when they don't need that support anymore. And then if you haven't already tell from the name of individual placement and support, we are all about the individual job seeker. We are listening to their preferences at every stage of services. So from our initial getting to know you period, where we do a career profile to get to know them as a person and get to know their employment skills, strengths, and preferences, and their day-to-day activities and interests, to their job search and going out and talking to employers with or without them, going forward to those job supports. We are listening to the job seekers as the experts on themselves to know really sort of how, what, where, when, and sort of why these services and supports happen. So that might mean, frequent conversations around disclosure. It might mean, updates to that conversation around benefits. It might mean, frequent communication around those job supports. We want to make sure that our job seekers feel supported and feel heard and have a strong guiding hand in these services. I often like to think of our job seekers being in the driver's seat and we're kind of GPS, and that if they want to reroute, then we will reroute. And if they punch in a new address, new location, then we're kind of going along with them and providing information and resources along the way. I'm going to go ahead and take a break from talking now and pass it along to the next speaker. Danny, could you remind me who is going next?
It's Adelia, I think.
Okay.
And I might, Amanda, if I might interject, I might even
go for
say,
it.
yeah, I might even just kind of open it up to the group right now. I think we
kind
of hit folks with a fire hose of information.
I did. I'm sorry. If anyone has
Yeah.
questions.
I have a question.
I think we have some questions. Let's go in the room first and then we'll go to the ones online.
Thank you so much. I absolutely love this idea as a clinician, knowing that there are clients out there who could definitely benefit from these services. I was wondering what qualifies somebody for these services and who is the lead on the team? Is there a lead?
Chris, you want to take that one?
Yeah, I can jump in. So, in order for somebody, in line with the practice principle here and the zero exclusion approach, in order for somebody to be eligible for services basically they have to meet specialty mental health criteria for one. But besides that, a person's stated interest in wanting to, it's super low barrier. Like if somebody wants to go back to work, that's all we need to hear. And we can start engaging, folks immediately in what that looks like, for them.
Perfect. And
it's as simple as that. Yeah.
Awesome. And who is the lead out on the teams?
It really depends on the staffing pattern and the team structure. It can range from like if you're working in a smaller county and you don't have that many teams, let's just say you have one FSP program. Typically what that would look like is you would have an employment specialist on the team, and then that person would be reporting directly to whoever the team leader or the program manager is. So in that sense, it's a little bit of a challenge because the team leader then has to wear kind of two hats. They have to be aware of, IPS and the practice principles and know, what the requirements are as far as, monitoring certain key performance indicators of the supported employment service and the requirements of the ES, because the employment specialist, that job is a lot different, looks a lot different than, a typical clinical case manager. When you think of the employment services specifically, and you think about the full service, like the team as a whole, the employment specialist is always going to be working with a subset of the folks who are open to that service, right? So part of the model for IPS is there are relatively low caseloads. So the program participant to employment specialist ratio is a 20-to-1. So we don't want to see, ideally, we don't want to see caseloads larger than 20 per 1.0 FTE employment specialist. And that really enables the employment specialist, like Amanda was saying, when we're looking at the practice principles, like being really person-centered and really being able to get to know that person, what their strengths are, what their skills are, what their interests are, as well as what their challenges and their barriers are, which is a big divergence from, a lot of traditional voc rehab programs. When you think about that traditional approach where you may have like one, employment vocational specialist, but they've got, a couple hundred people on a caseload. It's really hard for them to provide that very individualized, person-centered service. So the team, think of a team of, let's say there's 100 people, on a team. The employment specialist would be working with 20 folks at any given time. So the team leader would have to kind of wear those two hats, like managing the full caseload, but then also being able to, to spend time and attention on that subset of folks who are receiving that employment service as well. And that 20 at any given time, I just want to emphasize that is very much a dynamic sort of like caseload that the employment specialist is handling, because folks come through the door, and we talk about like stages of change. Somebody may come through the door and is just like raring to go. They're super action oriented. They're focused. They have a goal. They know what they want to do. They may even tell you like, I know exactly where I want to work. I want to work at that Home Depot right there on Main Street, which makes it really easy, right, for the employment specialist to kind of go out there and start immediately contact employers. And then you might have some folks that are interested and say, yeah, I want to do this. And the employment specialist has capacity, but it's still very much, an exploratory process. We've got to figure it out, what it is that they're interested in, what they've done in the past, what's worked, what hasn't worked. They may still kind of be on the fence, about really kind of wanting to go back to work. So we've got to unpack kind of what's behind that. The biggest reason why folks are reluctant, the studies have shown to go back to work is their fear of losing benefits. So that's why, one of the core practice principles that, Amanda shared is that everyone who has access to this service will also have individual specialized benefits counseling, because everyone's individual situation is a little bit different. We may have folks who just have SSI. We may have folks who have a combination of SSI and SSDI. They may have housing subsidies, right? SNAP benefits, any program or entitlement that is means tested. We want to make sure that the program participant is sitting down with a benefits counselor. We can talk specifically about their situation. So it's, because the world of benefits, we're talking federal level benefits, state level benefits, local level benefits that all have, they're very complex and all have their own rules and regulations and thresholds. So it's really not, it doesn't make much sense for the employment specialist to have to stay on top of all of those rules. It really makes more sense to connect with a certified work incentives planner to provide those specialized benefits counseling.
Thank you so much. Yeah, thanks. I'm going to stop on questions just for a moment. I want to make sure to give Adelia a chance to speak, and also mention we have a link to our issue brief that's included in the materials for today that goes over, the second page talks about some of the benefits and concerns that people have sometimes keep them away from even seeking employment, which we don't want to happen. We want them to understand that there are ways for them to keep benefits and work. So Adelia, do you want to comment on this topic?
Yes, thank you. I'm Idalia Matthews. I'm the former program director over at Interim Incorporated for Employment Services. I recently stepped into a new position, and I'll be honest, when I first heard of IPS, I was like, I don't know about this, and my former supervisor purchased books for us, and Chris put in the chat ipsworks.org. There is some information on there. You could purchase books. There's a lot of free information also available. You could also print out the fidelity scale to see where you are with your program. And we do that on an annual basis. But when we started looking into IPS, it's like, wait, we're doing that already. Wait, we're already doing that. We're already collaborating with the county. So even though we weren't able to embed and be in the same offices as them, they still attend their treatment team meetings on a weekly basis. The job development was one of those things, the 6 employer contacts that the staff have to do on a weekly basis. That initially was a challenge for them to be able to find the time, but with the smaller caseload, it does help. And then I also had a lot of introverted staff. So it's like, how can I make this work? So paired them up together. Let's do it. Let's go. And Chris actually provided a training to us in Alameda County years ago, where we went and we talked about the 3 cups of tea, how to engage with employers. So as Amanda had mentioned, you want to learn more about the employer versus are you hiring, because they're going to say, yeah, go ahead, apply online, and you're not really going to build a connection. So it's about feeling comfortable and building a connection. And if it's a mom and pop store, maybe they're going to hire just their family until they get to know you, right? And so we have had jobs here around the area where they've been like, you know what? I'm going to give you a chance. You come in here. So I had one employment counselor that was going there at least once a week, made friends with the owner of the restaurant, and he gave his client a shot as a dishwasher. And so we want to build those connections, whatever it might be, going in there, even if it's buying something small, whatever it might be, but building those connections and making sure that the staff feels comfortable. But there is a lot of information on the website, and a lot of the things that we were already doing was like meeting people where they are, connecting them to the benefits counseling, really making sure that we were always collaborating with the county. But then the things that we weren't doing was the things like the job development, like the 6 employer contacts. So that was a big challenge, as I mentioned. And then we were already collaborating with the county, but we weren't going to their weekly team meetings. So we started doing that and implementing that. And then also reviewing our fidelity scale on an annual basis and really sitting with the team and really breaking it out into 2 sections, because you can really, where did we improve, or how can we improve on this? Where have we, fallen short? Because we want to make sure that we are providing services to fidelity. The one thing that has been challenging, I will say, is that rapid job search, and not so much because we just have, a lot of people waiting to come into the program. And so I would say that really structuring and meeting people where they're at, if it is because with our program, for instance, opening them to Department of Rehab, we're not always able to open them as quickly as we'd like, but we're going to meet people where they're at. And at the very first contact, we're going to provide them job leads. Where is it that they want to, maybe that they're looking at the job leads and, oh, that one looks interesting. And if they want to apply, we'll help them apply. So meeting people where they're at, so that maybe by the time that they are already opening to Department of Rehab, they might already have an interview. Sometimes they already have a job, and that's okay, because the goal is to help them get there and to help them find employment.
Great. Yeah, thank you so much, Adelia. And she mentioned the Department of Rehab. So that is something that the counties will be hopefully collaborating and creating memos of understanding or relationships with all of the DOR offices and and contractors throughout California. So it's not just behavioral health. It is complicated putting together these programs. On the DOR side, Department of Rehabilitation has the vocational counselors and, you know, a lot of knowledge about employment. And then on the behavioral health side, they have, you know, the piece of understanding the needs of people with mental illness and having all of the different providers and staff. So integrating and collaborating is so important, and it is complicated, and it's complicated with funding as well. Did either of any of the presenters want to comment at all on barriers or challenges that you wanted to maybe have the boards and commissions bring up to their counties? Or if you just want to kind of give them a directive to say, encourage your counties to get this going?
Do it, jump in and do it. I don't know, maybe just kind of like a word of advice. So like this is a very, you know, dense, you know, information, but I think, you know, when we boil it down to the 8 practice principles, I think so long as you align as an agency, as a system, you know, if you align with those core practice principles, you know, predominantly like, you know, are we person-centered? Are we strengths-based? Are we possibility-minded? Like, you know, not know how, like, if that's how we are, then like uptake of this model is going to be, relatively easy. It's just a matter of jumping in and doing it, but within your respective systems, right? So we have a number of years here to implement, you know, to fidelity, right? The next 3-year plan, there's no, you know, strict requirements around fidelity, but starting in 2029, you know, the state is going to expect all of the FSP programs to have not only IPS, but, you know, serve community treatment and other evidence-based practices. The good thing is that the IPS Employment Center, right, the mothership, Amanda called it, and the links that I put in the chat there, these are the folks who developed the model, and they have been named as the Center of Excellence for California. So, you know, over the next 3 years, they are going to be rolling out training and helping, you know, with technical assistance and implementation. But in the meantime, you know, I would look, you know, I would encourage counties to implement like on a measured basis. Like I put the fidelity scale, I put an implementation plan, and I put the IPS agency readiness checklist in there. And that'll just really help you think about like who are those providers, who are those teams within our respective systems of care that are just like stellar, awesome. Like when we talk about person-centered planning, strengths-based, like they are already with that business. Like it's not going to be a tough sell. Identify those programs and those teams and think about, as if we're going to implement, as far as planning this out, start with those teams first, right? Start with the folks who are going to have, we're going to have buy-in, the folks that are curious, the folks that are willing to change, things and change up the ways that, services are delivered, what the staffing pattern looks like, sort of organizationally, the ones that are able to shift and that are nimble and that embrace, new things. Start with those agencies and those programs so that you can demonstrate success and then build upon that and then start scaling out more and more and more so that by the time, year 3 rolls around, we've kind of scaled out. We've got year 1, year 2, year 3. That's sort of like the advice that I would give. Because in Alameda County, we've implemented IPS since 2010, and that's exactly how we rolled it out. We started very small with 1 county operated program and 2 CBO agencies. And that was through an RFP process. So we had some seed money that was involved, and we said, hey, we got this new model. We want to try this out. So we had them, apply for this money, and we were able to fund employment specialists, and we laid it all out. We provided the training. And then, we were able to demonstrate the success with those programs and then slowly scale out from there.
Right. Okay, thanks. Amanda and Adelia, I want to give you a chance if you have any final closing words.
Yeah, so here in San Diego, we say IPS yes, trademark pending. We want like Chris said, we want a chorus of champions. Solos are great, but we want it to be loud and we want people to hear it. So identify your champions and then just keep adding to that group to amp up the volume. And I do just want to say, make sure that your champions are coming from all the different levels of practice and service. We want executive leadership, we want external leadership, we want direct service providers, we want peer supports, we want family members, we want service consumers, we want everybody's voices as part of this conversation. And also, I do just want to kind of repeat what Chris said a little bit, to start slow and grow. I think that is maybe one of the things where San Diego, I think, maybe got a little bit too enthusiastic about IPS and sort of had implemented so many programs at once that it's been, everybody just trying to keep pace. And so definitely starting slow and grow, starting with what you do well, doing sort of a crosswalk between what you're doing currently and then transitioning to IPS. The program that I'm currently with, we're a 30+ year contract, and we've only been doing IPS for the last 5 years. It's been a work in progress, and really the first several months, if not year, was just really about identifying where are we already doing this, but maybe calling it by a different name. What are we changing or updating or shifting slightly? What's sort of our incremental implementation plan? So just because you say okay, now we're doing IPS, doesn't mean you have to start doing the full fidelity that next day. Really think about, okay, what does our implementation plan look like? What are we hitting first in terms of fidelity, and what is our sort of our 1 month fidelity goal and our 6 month fidelity goal? And when you do sort of that baseline fidelity review after about 6 months, you're really just aiming for that baseline fidelity, right? That think about getting 3s, maybe not necessarily 5s on every single one. A 3 on the fidelity scale means you're doing the model, and you can get a 3 on each of the items and get a fidelity score. You are doing IPS if you get a 3 on each of those items, and then you have room to improve and room to grow. So I think it's just thinking about, it's not everything all at once. And I think providing that education and support to folks involved so that they don't immediately go, it's too much change too fast. And thinking about how and who is sort of leading this change effort.
Thank you. Adelia?
I just want to really emphasize how much it really does work. I know that for the county, we have program outcomes, and once we started implementing more of the elements of IPS, we saw a jump in our numbers. And so, and then clients, they're more likely to reach out if they need support. We have people that still keep in contact with us years later, and they're still employed. So it is very helpful to have that as a model.
Great to hear. Well, okay. Thank you all. Really appreciate this. Oh, we have a question in the room. 2 questions in the room, and they'll be quick, right? Because we're at the end of the time.
Yes, hello. Thank you for your presentation. I have a couple of questions. Since I live in a county that I think is not one that you're currently working in. One is, I'd be interested to, and maybe you have just a fact sheet somewhere that compares and contrasts your program with Department of Rehabilitation. I would be interested in knowing what you do that's different from Department of Rehabilitation. Like, can you send people for training, or do they start at, say, Home Depot, and that's as far as they're ever going to go because they can't get training into something else? So that's one question. Another question is, I have clients that do work, and then we have clients that want to work, have tried to work, and that have been fired from many, many jobs, which really adds to their feeling of unworthiness. And I wonder what you do with people like that.
Okay, I'm gonna have them follow up if they have comments. We can put it in the chat and I'll forward it to you, because we do need to wrap up now. And I saw one other hand go up. Did you have a quick question?
Just a comment.
Oh, okay.
I would just like to clarify the acronyms in this presentation. In the beginning, there was a CASRA acronym, and that stands for California Association of Social Rehab Agencies. So thank you very much.
Thank you. Yeah, thank you to CASRA and thank you to CASRA members. Thank you to all the speakers. Really appreciate the work that you're doing and that you took the time today to share this with us. And we're recording and we'll share this in the future with others. Thanks so much.
Thank you.
I did put my email in the chat, so if anybody has questions or you want to talk some more, I'm always game for a conversation around supported employment. So please
Great.
do feel free to reach out.
Okay, much appreciated. All right, so we're going to take a short break and then we're going to transition to our governing board meeting. Let's start again at 3:30. So we have 6 minutes for a break.
That's good. Right?
Okay, welcome back, everybody. We're going to get started with our governing board meeting.
Oh, welcome, everyone. My name's Bill Stewart. I'm the president, and I want to welcome you to CALBHB Annual Governing Board meeting. We'd like to start off with agenda item number 1, opening comments for non-agenda items. So if anybody in the room have an opening comment for non-agenda items they'd like to share.
This is the time that the governing board usually, they'll bring up items that are concerns regarding behavioral health, which you'll have a discussion on after this meeting as well. And or if it's resources that they need within their own county, sometimes they'll mention some of those issues.
Yes. And we do have a few governing board members online. So if you had a non-agenda item you'd like to bring up, at this time, this would be a good time. You just show your hands where Teresa can see it easier.
Or they can just come off of mute.
Okay.
And talk.
I can't see any, but.
I just thought I'd pull up for everybody. This is a picture of the current governing board. As you know, Bill is our president, and we have members throughout California who were either appointed between elections or they were elected in their regions. And our newest member is Patricia Wenzel, and she is from Sacramento County. We try our best to model the type of membership that you should have within your own counties in terms of the requirements and the diversity.
Okay, not seeing anybody wanting to have open. Yes.
Oh.
Okay, we have one in the room.
Good afternoon. This is JD, Chair for Solano County. I got a clear understanding when I was in the Patients' Right Committee on the legislation bills. Mike Phelps was very articulate with the presentation in explaining some of the bills and things that's going on. And I just want to thank him for that, because I got a clear understanding of a whole bunch of bills that he expounded on in that committee. So now I have a better understanding of what's going on in the patient's rights in that area. Thank you.
Thank you. Yeah, for those that are just connecting today, many of our members were here all week. There's a meeting that comes right before CalBHBC's meeting. It's the California Behavioral Health Planning Council. And so he was referring to their Patients' Rights Committee.
All right, well, thank you, JD. Moving on to agenda item number 2, and the minutes from the May 16th, 2024. 2025, thank you, Christine. And it's in your package. We have a motion to accept.
Motion to accept, Stacy Dalglish.
Thank you. Do we have a second?
Second.
Oh,
Harriet.
Harriet. Yes, thank you, Harriet. You and Benny said it at the same time, but.
Oh, okay.
Yeah. No, but I'd have to run over there to Benny. So. Thank you. Hearing a first and a second. Teresa, can we do a roll call, or do we need to do a roll call on this one? Oh, sorry. Yeah, I always forget about that part. Is there any discussion? No. Okay. I'm not hearing a need for discussion.
Okay.
Teresa?
All right. So Bill?
Yes.
Stacy?
Yes. Yes.
Did I heard a yes from Christine? Oh, it was, Patricia.
Abstain.
JD?
Yes.
Benny?
Aye.
Christine? Harriet?
Yes.
Jonathan?
Yes.
and Michael,
Yes.
and Annie?
Abstain. I wasn't there. Sorry.
Okay,
Thank you.
that's okay. Is there anybody I'm missing? All right, it was, the motion passed.
Thank you. Motion passed. Moving on to agenda item number 3, the financials as of June 12th, 2025. I'm going to turn the floor over to Teresa. And the financials are in your package.
Okay, yes, for those in the room, the package was provided with the financials, and for those online, if you go to the meeting materials webpage that I gave you the link to, you can select the financials on the agenda on that page and review them. So within this document, I think we've done okay in terms of staying within our budget for the year. We currently have a lot of money in the bank as well. Total assets right now are over $106,000. That's going to change within the next week because we're in the middle of our annual meeting, which is off-site. So we have the travel expenses for our own governing board members as well as members in counties close to this area. And then the second page shows our accounts receivable. I'm expecting I know that the Commission for Behavioral Health will pay their bills. So we should be receiving over 17,000 soon from them. And then there were 3 counties that haven't paid dues yet. I think they're working on it. So hopefully we'll get 100% this year. And then the last 2 pages of the report just go into more detail in terms of actual expenses. And it shows the numbers in the middle column are the actuals. That's what we actually spent. And then the column on the right is what we budgeted for. So this time last year, we created a budget and tried to stay within that budget, or I got approval if we were not going to stay within that budget. So that helped guide us. And later, actually, the next item on the agenda is to review the budget for the next fiscal year, which for those in the room, it's on the green paper. You want to take a vote on the financials?
Yes. Can I have a motion to approve the financials?
I move that we approve. Oops.
Oh, Christine in the room beat all of you. So can I have a second? Thank you, Patricia.
We can't be fast enough here online.
Hearing a first and second, is there any discussion?
For the question, Teresa, regarding the travel, you mentioned that there would be additional expenses coming out for this particular trip. And I see that the budgeted amount was 13 and we spent 9. Will we still be within our budget once we paid for those, do you think? Or I'm also asking because I saw on the draft that it looked like you had used
that number.
Yeah, and so I just thought maybe, but I was curious.
I think we're pretty close to within that, more or less. I won't know till tomorrow or next week when they give me my final numbers.
Thank you. JD?
I do recall when we spoke that it was supposed to be something for advocacy, and it's still the same. That are we not putting out for?
We have we did not contribute to anything that was advocacy related with our money, although we put time in to advocacy. So when I report to the state and federal government, I will create a number for the staff time toward advocacy. But in terms of money out of the bank, It went to payroll.
Thank you.
Any other questions in the room? Any questions from board members online? Well, we had a comment. Great job, Teresa.
Thank you.
Okay, okay, Teresa, do we do a roll call for this one? Yes.
Okay, Bill,
Yes.
Stacy,
Yes.
Patricia,
Aye.
Yes.
that was JD, sorry, JD, Benny,
Aye.
and Christine.
Yes.
And then online, Harriet,
Yes.
I'm having a hard time with my screen, just a second. Okay, Jonathan,
Yes.
Michael,
Yes.
Annie.
Yes.
Okay, the motion passes.
Thank you. Moving on to agenda item number 4, the budget for 2024-2026. Like mentioned earlier, for those online, the draft is an attachment that was sent out to you. And for those in the room, it's in your package. And as Teresa pointed out, it's the green paper. So I'll turn the floor over to Teresa.
Okay, so, the budget for every year is our best guess for what we'll need to spend on each item. And it is, as Stacy pointed out, oftentimes I'm looking at what our past expenses were for the year. The revenue that we're expecting this year, we're proposing to continue with the same request for dues from each of the counties that we did the last 3 years, I think. And so that number will probably be the same. And then in terms of the money that we received from the Commission for Behavioral Health, that we requested more money. But we don't yet know exactly how much, if they'll say yes to our request. I do have support from staff, but there has been changes at the Commission for Behavioral Health, and the commissioners want to review every contract now. And it needs to go, so the contracts need to go through 2 committees. The program committee will review it, and then the budget and fiscal committee will review it. And then the commission will vote whether or not they will approve it. In the past, it just went through staff. It was a number that was less than needed to go out to bid. So the executive director would approve it through his discretionary funds. So it's a new process. I think it's just going to be a little delayed in getting an approval. We won't probably know till toward the end of July if it's approved. So if it's not approved, and if it's a different number at that time, I will revise our budget and ask the governing board to vote again on it. So I wanted to, fill you in on all of that.
Do you want to vote on it first and ask questions later, or do you want to ask questions now?
Go ahead and ask questions.
Well, I was just particularly looking at the number for travel and expenses, because I guess I hadn't noticed that you offer for someone from the local area when we hold a meeting to come, and we pay for their lodging. You look like that might not be true.
From
Oh,
your
yes.
mouth,
Oh,
and just
sure.
all the static. Unless your
it's up
jewelry.
there. Must be that, right? No, I
has some
keep
beautiful
forgetting
jewelry.
about this little
Go
thing
ahead.
right here. And so I guess I didn't even know that, or it would have been something that possibly our commission might have discussed, who might want to come.
Right.
And I don't know how often we get somebody from the local area. But if we haven't been getting them, and so they're not included in the actual, we might want to think about whether we need to increase the budgeted amount and then revisit the budget amount later, next year.
Okay, yeah, LA County is always an unknown because we've had years where we've spent like $6,000 on training because we contracted and did like 8 trainings for you. So we're always wondering about LA County. So that's one of the guessing kind of factors that goes into this. But we have for a number of years, probably 8 years now, offered at least one person from every county to come to our meetings, and we'll pay their travel and expenses and lodging. And yeah, it's on our invitation.
So I'm looking at the billable deliverables, excuse me. And it's a minor increase from last year. Is that what you requested, or is that what you're thinking we might get?
That is what I requested.
Okay, so you didn't request much of an increase, just a.
Oh, this actually last year, it might not ring a bell. I don't know if you remember as well as I do, but there was an invoice that was outstanding last year it was over 1 year that it was over. Yeah, and that's why our budget, it was easier to put together a budget last year because I knew that money was on its way.
I see.
So that's why it looks the same, but that's not what the contract was. That
So
was
last
really
year's budget included the past due deliverable that was over a year.
Past due.
Okay,
right.
So it is
This
a significant
right.
increase then.
Right. Our contract has been at 75,500.
Yeah, that makes sense. I remember that. Okay, thank you.
So I'd like to speak about the massive deficit we'll be operating on. Our budget is in the deficit, right? $13,000.
I think we'll have to take it out of the bank.
Yeah.
All right. Any other questions? Okay. Want to do a motion?
Oh, yes. Stacy agrees, motion to approve. And do I have a second?
Oh, you did?
Oh, yes.
Oh, for the budget? Oh, okay. Okay. You did already. Okay.
Sorry
So
about
we
that.
have a motion and a second. Okay, let's go with the roll call vote. Bill?
Yes.
Yes, Stacy.
Patricia?
Aye.
JD?
Yes.
Aye.
That was Benny and Christine.
I said
Yeah.
yes already. Yes.
I'm trying to model good behavior here. Harriet?
Yes.
Jonathan? Maybe he dropped off.
No, I'm here. I'm sorry. I had put myself on mute. Yes, yes.
I just noted that my notes, my first and second were actually for the financials and not for the budget.
Hello, did you hear that?
Yeah, we heard you, Jonathan. There was a problem in the room. They're gonna
Okay.
have to do we're gonna do this vote again. Let's have a motion. Okay. Sorry for the confusion.
Yes.
All right.
So we're gonna do the motion to approve over. Do we have a Stacy that agrees? Moved and Benny second. Thank you. So Teresa, if we can do the vote over, yeah?
Okay, Bill?
Yes.
He's getting his exercise.
Stacy,
Stacy?
yes.
Patricia?
Aye.
JD?
Yes.
And Benny?
Aye.
And Christine?
Yes.
Good. And Jonathan?
Yes.
Harriet?
Yes.
Annie? Annie? You're on mute. Okay, well, the motion passed.
All right, thank you. We're gonna move on to agenda item number Number 5.
Okay,
Oh, yeah, Michael.
so the election of officers.
Okay, Michael, you didn't get Michael.
Oh, Michael, sorry. What's your vote, Michael?
Yes,
Thank you. Sorry about that.
no problem.
Thank you.
All right, so the election of officers, I hear that Stacy is going to help guide us through this item.
Agenda item number 5, election of officers. The nominating committee, and I want to thank you, recommended the slate below. For the term July 1st of this year, 2025, to June 30th, 2026. For president, the nominations are these. President, Bill Stewart. Vice President, Michael Rodriguez. Secretary Treasurer, Christine Ataya. No, tell me because I really want it. Ataya, okay. Would you like me to proceed, and are we going to do a vote for the entire slate, or are we going to vote individually?
Can you call for it, ask if anybody else would like to nominate, any other nominations?
Is there anyone else in the room who would like to, on the board, who would like to nominate someone or would like to nominate themselves to one of these positions?
Or, yeah.
Seeing
not
none.
Just in the room, but online too.
All right, well, but Michael he's already on the slate.
Okay.
Are there more governing board members on the call? Oh, Jonathan, all right, Jonathan.
I don't hear anything.
Oh, and Harriet,
think
all
we're
right.
probably okay.
So if any of the members online are interested in running, nominating themselves or someone else, please speak up. Hearing no one. I ask our chair, are we going to vote for the slate or are we going to vote individually?
Yeah, let's let him do
Okay.
the motion or call for a motion.
Thank you, Stacy. I'm going to call for a motion to approve the slate. And do I have a motion?
I'm move that we.
Okay.
Patricia
And
motion and then Harriet second. Thank you. Teresa, can we have a roll call?
Yes. Bill?
Yes.
Stacy?
Approve.
Patricia?
Approve.
JD?
Yes.
Benny?
Yes.
Yes.
Christine? Yes. Online, Harriet?
Approve.
Jonathan?
Yes.
Michael?
Yes.
Annie?
Yes.
Great, thank you. Motion unanimously passes. Thank you all.
Yeah. And another thanks to the nominating committee for their efforts in putting in the time. I'm gonna move to agenda item number 6, the annual report for 2024, 2025.
All right, you want me to review this
Yes,
with you?
please,
Okay, so every year, as part of our contract with the Commission for Behavioral Health, we are asked to do a report and to just as we're ending our contract for the fiscal year. And they have a specific format. So if you think that it's redundant, it's partly because there is a specific requirement for how this is put together. But it's nice to do this every year to get an idea of what we've done, what kind of issues we've advocated for, and what we've heard from the boards and commissions in terms of issues and raised to the top priority list for our own advocacy. It's also nice to just review all of the work that's done during the year and and then also to identify what areas we could work on and maybe improve, goals for the future. So it goes through all of those things. I can give you just a little overview on each of the topics if you're okay with that. All right. So the beginning just talks about the executive summary and the background. They talk about what is our role, what's our mission, and touch on some of the areas where we've really done a lot of collaborative work, statewide collaboration, and listed all of the different organizations that we've been in contact with through our work. And there's probably about, I don't know, it looks like about 20 organizations that we've worked with collaboratively, and that helps us to understand issues better and also to work on them together in a meaningful way. And then when we look at, let's see, I'm going to move on to the service to the behavioral health boards. In that section, it goes through what do we do in terms of fulfilling our mission. And, a big part of that is just listening through the meetings like today's meeting. We're taking notes when we hear about issues from the counties. And there's always phone calls and emails coming in with questions, either from like the administrative liaison from the counties or the chair or other members will be reaching out to us with questions, and we'll be providing information. And then we respond also with issue briefs and website resources, and then policy and legislative advocacy and collaboration with statewide partners. In terms of the issues that we worked on for advocacy this year, one is related right now that we have as a bill that we're supporting. It's related to access. It's AB 384. It's the Mental Health Protection Act. And then budget advocacy, we've worked on letters of support to increase adult residential facilities and residential care facilities for the elderly that serve people with behavioral health needs.
I bet you because you don't eat, all you eat is this whole time.
I'm going to put her on mute.
Sorry.
That's all right. And then the California Warm Line, we did advocacy with a letter because that is a resource that's being used by individuals throughout California and is relied on more and more in terms of access for counties. Since the governor's revised budget took out that as an item, which is, I think it was around $20 million, we've asked for it to be put back. The California Reducing Disparities Project was also an item that was removed from the budget. I think it was at $15 million. This has been an ongoing project. I think maybe it's gone on for about 10 years now. It had one more year of funding that had been approved by the legislature. And then we had expected maybe the Department of Public Health using Behavioral Health Services Act funding to start funding their programs. And they just completely pulled that funding. So we heard this week that the legislature has put that funding back into the budget. It's not an approved budget yet. So we're hopeful that that project, which I think it funds about 30 different contractors, or not, they're contractors with the county or with the state. They're mostly community-based, like community organizations, like tribal groups or ethnic or cultural groups that have these different contracts. And then Medicaid, we did some federal advocacy this year. did not want to see people's access to behavioral health reduced because the federal government was considering just taking billions and billions out of Medicaid. We're still concerned with that one. I even had a meeting in Washington, D.C. with Senator Padilla's policy advisor over health and got advice. And I'm hopeful, based on the conversation with him, that we won't see the funding reduced in the way that it looks like it's going to be reduced. But the news does not look good on TV, so we'll see what happens. But we reached out. Yeah, go ahead, Benny.
Yes. Pretty.
Well, he was not. He was thrown down and handcuffed because he asked a question.
And Benny asked if that's the same Padilla that got thrown down. For those online, I couldn't hear him.
Yes, that was him. And we reached out to the counties also, asking for advocacy and asking for people to ask for meetings with their local House of Representatives representative. And so some of the counties responded. I think we got some letters out, and I think it really is important for people to be meeting with their legislators. The other item is children and youth. We're supporting a bill, SB 531, student mental health education. And then homelessness and housing, there's a bill, AB 804, which allows for an increase in billing for Medi-Cal housing. And then we also did advocacy. I think I have this. I mentioned this earlier. It's the advocacy for increasing the adult residential facilities and residential care facilities for the elderly. And then performance outcomes measures. I've had a strong participation with the California Behavioral Health Transformation, Performance and Equity Work Group, which is being facilitated by the Department of Healthcare Services. And that's been a long-term goal for our association. Over the years, we've been saying we need to standardize performance measures. Otherwise, the counties can't comment on them because some of them don't have any, and they're all different. And we need to be able to compare and know where our strengths are and where our challenges are. So I think we're getting there. And then lots of other issues are on our website. And then in terms of all of the meetings and trainings we did this year, we did 5 different regional meetings and trainings. And then we had board-specific trainings. I actually went out to 10 different counties and did in-person trainings this year. And when I looked at the budget for this coming year, I kept in mind that I don't think I'll do 10 counties again because it was more travel than I think I am comfortable with, since I was starting to wake up and wonder where I was. So those are the main things there. In terms of the, because of the Behavioral Health Services Act, we have, or I have tried to really raise the awareness of the Commission for Behavioral Health on the need to have more of a collaboration with the counties, so that we can better oversee the system, and to leverage the 59 boards and commissions and their requirement to review and comment on performance. So I'm hoping that there's going to be, something more built in to the review system statewide that the local counties can use to comment. So I'm hoping over the years we see something that's really easier to look at and easier to comment on and easier to compare county to county. And then what else? We had, I've also asked I also have identified a need to increase community engagement. And I've been, I put more of a description together in the contract that I asked for with the Commission for Behavioral Health. But, increasing racial, ethnic, and cultural responsiveness means that we need to have better community engagement in the planning processes. So we'll continue to work on that as well.
Thank you, Teresa. Did you want to take a break because next issue-based discussion is next on our agenda?
So do we need to adopt the annual report or?
Yes, thank you, Harriet and Benny.
No, I wanted to first commend Teresa on such a comprehensive report.
Thank you, Harriet.
All right, so do I have a motion to approve? Thank you, Benny. And do we have a second? Stacy. Thank you.
All right, so Bill?
Yes.
Stacy?
Yes.
Patricia?
Yes.
JD?
Yes.
Benny?
Yes.
Christine?
Yes.
Great. And then online, Harriet?
Yes.
Jonathan?
Yes.
Michael?
Yes.
Annie?
Yes.
All right, thank you all. Okay, so we can take a short break. Bill, I'll let you finish up this meeting and maybe we'll take a little break after this.
Okay, well.
If you want to, we don't have to, we can keep going.
Yeah.
Keep going?
Yeah, let's
Okay,
keep
we'll
going.
keep going. All right. But yeah, go ahead.
Is it to
All right.
4:30 or 5:30?
The governing board meeting was going to go to 4:30, but we're finishing up a little early. So yeah.
Yes, so we can finish up the governing board meeting because the next one will be issue-based discussion. So can call. Thank you, Christine. She made a motion to adjourn the meeting and Patricia seconded the motion. So I thank everyone for their participation and this meeting is now adjourned. Thank you.
Thank you. Be well.
You as well. So now we're going to continue with the issue brief-based discussion. So this is anyone from local behavioral health boards or commission members are asked to briefly introduce any discussion local success or and challenges related to their behavioral health offerings. Yes, Katie, did you want to start it off?
All right,
Hey.
so we have, yeah, so, anything is welcome from you all. You can tell us, issues related to behavioral health, challenges or successes. And if you have issues just in terms of boards, if you need some technical assistance or resources or training, this is a good time to let us know. Go ahead, JD.
Good afternoon. This is JD, Chair for Solano County Health Behavioral Advisory Board. One of our challenges is getting the youth. Like Christine, I canvassed the college. I talked to everybody on the college campus, EOPS, financial aid. I put up flyers on the campus, and we still have not got a youth on our board. So that's one of our main challenges in Solano County that I've been continuously, beating up the campus, trying to get a youth because, because I heard, they got a youth off the campus. So I've been beating up Solano Community College weekly, trying to get a youth on board, talking to different agencies and departments on the campus. And this has been going on since January that I've been, trying to promote. So that's one of the main challenges that we're having right now is just trying to get a youth to our board right now. So I'm just looking for any suggestions or advice that that we could help. That may help us, or I could take a lead on to try to get us the youth.
Thank you.
Can I comment on that?
Go ahead.
Go ahead.
Yes, so in YOLO, we reached out to UC Davis NAMI, and we ended up getting a board member from UC Davis NAMI. So it's possible that there's some UC Davis NAMI folks that live in Solano County because you're just one county over. So I would reach out, and I can give you this woman's name actually, or I can post it here, who's on our board, who I think is their president, and maybe she could help you.
Okay, thank you.
So I thank you, Jonathan. I think that was a really great suggestion because that is targeted recruitment rather than just out there. The other thing I was going to say is we actually got our person by personal invitation, so if you know someone who is interested in behavioral health, if people when they're invited tend to feel much more welcome and much more inclined to actually apply. So that's my suggestion.
Also, I want to suggest the youth that come to your meeting, be it they speak up or just in the crowd, it's a good promotion. Because in San Diego County, we're doing online as well. So some people or some youth online contacted us about their interest in it. So.
So the first thing I want to say is I commend you, Bill. If you have a crowd at your commission or board meetings, I need to talk to you about that. But I spoke to, because we've had the same problem or difficulty, and I spoke with our supervisor's office to see how they would like to proceed, and then suggested NAMI and the colleges in the area, because high schools seemed like a good idea because they're much younger and we'd have them stay young for longer. But really, when you think about a high schooler's schedule versus a college student's schedule, it really was, better. So I know that they're reaching out to those entities. So that might be an idea to talk to your supervisor's office and see if they want to do that.
So I noticed in Solano County that there are some TAY programs, transition age youth programs. You might want to reach out to the people running those TAY programs and see if they have anybody who's receiving services who might be a good candidate to sit on your board.
Yes, and also when she mentioned that certain counties have clubhouse and they have advisory boards part of that clubhouse, so you can see if there's youth taking part in that as well.
Yeah, we also have not identified a transitional age youth member for our board yet. NAMI is absolutely a fantastic resource. I would also think, like you said, the NAMI clubs or any behavioral health clubs or mental health clubs on campuses. My question, I guess, is I assumed it was somebody that we were looking for, somebody with not just an age group, but with some sort of lived experience, either as a peer or a family member. So not, yeah, but that's always my point of view, is somebody with an insider, not again. So that's a little bit harder to identify sometimes, even for, well, the age group is difficult, period, because they're either out there building their lives and in school or making money or raising a family. And I don't know what the time commitment is, but for our board, it's about 8 hours a month. And so it's different to ask somebody to show up for a meeting once a month for, 2.5 hours and a little bit of travel time, 4 hours. But I think it's very important to be clear that when we do reach out to these individuals, that they have an understanding of what the time commitment is so that they're making an informed decision. So we hang on to them. Also, the commitment we usually ask for is about 3 years. And that's a long commitment for somebody at that age to even be considering. So that might be another part of the barriers that we're finding.
Hi, I'm from Santa Barbara County. We've reached out to, I think, some professors at UCSB and City College. And we have a couple of people on our board who are TAE members. And they're in college, and some are studying psychology and education classes. And so that's kind of a natural fit. Even if they have no family members, they have an interest. And that's what we need.
Mhm.
Thank you. NAMI on campus is a great idea. And then there's also active minds on campuses that you might look into. I would bet that there's one somewhere near you.
Maybe it's your earring.
Is there anyone online that'd like to share their thoughts on this? Or any issue, because it is open discussion. It's issue-based discussion, sorry.
This is Harriet. I think someone mentioned the NAMI, and I was just wondering if Clubhouse was a NAMI group, or if not, NAMI has a group that's dedicated for young people.
Oh.
They have pizza night. They work and meet together, and it's separate from the adult family group.
Thank you, Harriet.
Being very targeted with NAMI rather than just the overall group. Thank you.
Is that a group that's specific to San Francisco, or do you know if they have that throughout the state?
I think it's not part of the NAMI model.
Okay, thanks.
The other place that I suggested they look is our Alateen groups.
Mm-hmm.
By definition, they're already family members or.
Mm-hmm.
Okay, sounds like a good subject for our next newsletter.
Yes.
Okay. All right, then. Does anybody else have any other issues that they wanted to bring up? Yeah.
Okay, so Benny?
Yeah, we have some in the room. Just a second.
This is Benny from Imperial County. So let me kind of give you I think some of you know that my background was in law enforcement. I was a probation chief for several years. And one of the things that we saw in probation is a lot of the substance abusers finding their way into the criminal justice system. I mean, I think the last estimate I saw was like 70% of people in prison have a substance abuse problem. So in our county, when I got on the advisory board, I think it's been like 9 years. That was kind of one of the big things we had. I mean, how do we enhance our substance abuse treatment? How do we build that up and stuff? Because the county had very little programming. In fact, if it wasn't for faith-based programs, residential programs, we wouldn't have anything. So that was a challenge we had. So we've come a long ways. The county has adopted the substance abuse treatment program, and we've put 2 big clinics in 2 of our cities. Our challenge right now is in the northern city, which tends to have a real NIMBY population. They don't want to see a substance abuse treatment over there. Some of it's denial. Most of it seems to be there's a political group down there that they're affluent family, but a minority group that are fighting it and resisting it. So one of the things that we've done is we've been very active in our advisory board, and we've actually been engaged with the community. So they've been a couple of forums that they've had down there in the North County, and trying to tell them the advantages of it and what the plus is, and also bringing out law enforcement and telling them how many arrests they've had, and showing the use. And I've engaged in it, and along with some of the other advisory board members have engaged with at those forums, kind of trying to tell them from our aspect on it. I mention this because it's a challenge. I mean, not only do we have that NIMBY attitude, which is prevalent, but you know, we have these influential groups that make it really tough. So I just would encourage all our advisory board members to, it's like what Teresa was saying, our outreach, our support. I think this is part of our role in going out there and speaking to the community, speaking at the community, and giving them our educated opinions on what we need. So just sharing that.
Thank you, Benny.
So I think this is a longer discussion. I think it's a really interesting comment because I find it hard to believe that there are people who are resisting opportunities towards treatment and education towards this. We're not demanding it, we're not mandating, but you're offering an open space for those who want to engage in to benefit, and to say that there are no substance use disorders and that nobody would benefit kind of astounds me. We in our county, we're actually building, we're talking about, this is not what I was going to comment on, but we're talking about strengths-based is we're in the phase 2 of a new treatment center that is also deals with I'll just read it. A strategic initiative of San Bernardino County aimed at developing a comprehensive continuum to care to support the county's most vulnerable populations. And this includes residential treatment beds for individuals battling substance use disorders. It also includes housing, quality care, and everything on one campus. So one of the issues has been with many of things, mental health conditions and behavioral health conditions, is that you have a space for one thing and a space for another thing. And for people to be able to go through and figure out what they need to do, or to have somebody go along with them, makes it very difficult. But once you have everything on one campus, it's a very easy fix. And then once people, let's say, have gone through detox, they don't need to find housing elsewhere. They can naturally move to something else on the campus that is a lower care, and so on and so forth. And part of this longer term also includes permanent housing for individuals. And there's talks about other things, other modalities other than just treatment, but including things like nutrition and health and everything on one location. So something comprehensive like that, and it's a huge investment. I think I want to say it's 38.7 million, so it's a lot. But we started with one phase that was much smaller and are slowly incorporating it. So, one bite at a time. So that's a plus that's going on in our county. We have obviously have some strengths and successes. You asked about strengths, successes, and challenges. Some of our challenges is we're a huge county, and for those who are in the more central area, there are good services available. In some of the people in some of the counties, in some of my county, even in my district, there are areas that are so far from services that it makes it very difficult for people to access those services, even just a drive there, or sending out, we've got crisis teams, but sending out a crisis team to a very far locale where we go as far as Wrightwood. So that can be a big challenge. Strengths are clubhouses. Somebody asked what the clubhouses are. The clubhouses are wellness centers. So they're county wellness centers that include some options for behavioral health services, but also just community. So if people, whatever the people are looking for, so if somebody's looking for job placement, if somebody's looking for community, if somebody's looking for purpose, these county clubhouses offer all of that. A challenge that we've had is, and I'd like to know if anybody else has more successes, is our district advisory committee meetings have I would say, a long history of having very low attendance. And we've tried several different things to address this. And I know it has to do with time and whether it's online or in person and so on, but I wondered if anybody else had any success, and or if they have very high attendance, what that looks like.
And I want to mention, you called it district meetings. So some of these really large counties have districts or service areas where they have committees that can advise the commission. Just wanted to explain that. Some of the small counties that, no, not the small, not, yeah, but
Five districts.
you have five. Okay.
This is Christine from Napa County. A few years ago, we had a community outreach work group. And one of the things that we did, well, we got a logo design, which was great. And we also started doing monthly flyers about our topics. Now, my background's marketing, so that kind of helped a little. But, it would be hopefully a provocative headline and then some information about what the problem is and what we're going to be talking about. I email this to everybody, all the electeds in the county, all the faith-based organizations, all the nonprofits that have anything to do with behavioral health. And I won't say we don't have tons of people coming, but we did, at least initially, we were keeping track of how many people came, and we found that it does help. It brings people to the meetings. It doesn't bring a lot of people to the meetings. Sometimes if it's a topic that's of wide interest, I think the biggest one we had was, and this is truly the biggest, was about 20 people. And that was when we had a program related to the mental health needs and services for survivors of domestic violence. And that went out to a lot of women's organizations and they showed up. So anyway, it's worth a try, but that's what we do.
Thank you, Monica Caffey, San Bernardino County. Teresa, you have been the breath of fresh air to help us really to navigate that. I remember when you first came on and reestablishing the commissions in Riverside was one of the first training grounds that you provided. That part of the announcement that we do have a statewide board that helps to support boards and commissions across the state, that we have priorities and what they are, and sticking to those help to build trust in community where they found a connection. At one time, wraparound, for instance, 90 was really, really big, and we had many children and youth services. And so we would have partnerships with all the school districts. They would come to our meetings. We had a lot of of small business association, the chambers, they would come. Our DACs at one point during the early, of course, MHSA, and all the way truly, I would say until COVID, was at least in pretty much all of our districts having all of the stakeholders there. And that was just because of the strong partnerships that we had with all the stakeholders in the community. And they trusted that the priorities that we were speaking to actually aligned with their interests. We had a lot of community-based organizations that received contracts, that in the contracts that they were written, that in order for them to continue that support, they would have to attend the district advisory meetings and they would provide updates to the communities in which they served. This allowed those community members to get to know them a lot more personal. I think, like I said, a lot of it has to do with trust. All of us know how scary it is when you're seeking services and you're in a crisis and then you feel a little bit exhausted. And a lot of the community members felt that way. But they really were excited to be present because we had all of the deputy directors would actually attend these DAC meetings as well. The providers were there. Their presence brought out a lot of the attendance. And like I said, the draw was there. We also had great support with the board of supervisors in our districts, that their staff would be present. So they have a good list of individuals that they can connect with and invite. And so I believe that the collaboration and the investment, especially now with the changes that are taking place with the Behavioral Health Service Act, that model just needs to be implemented again. And I really appreciate the resources that you've given us, like you said, to help prioritize that so that language can be communicated in the local area to those who are not familiar with these processes and who to tap into to know how to revive them. Thank you.
We had a quick surprise last week in our budget hearings when one of our supervisors, actually the chair of our county supervisors, suggested that we spend some money and give some money to the Immigrant Defense Center in our community to provide therapy for children who are affected by immigration issues. And they passed it, and we're doing it. Couple $100,000 to a little more than that, to have 2 full-time counselors working with kids. So, and the idea came from one of her staff members.
This is Santa Barbara County?
Santa Barbara County. Yeah. Did it.
Okay, we have a couple more hands in the room. I don't know. Let me check. Yes, there are people in line. Go ahead.
This is Patricia from Sacramento County. This is not the first time I've heard information about IPS because we are implementing IPS in our county in our full service partnerships. And we have the first one has hired a couple of people. Apparently it's kind of hard to hire people to do this job, that it requires some special skills. And so they are developing their staffing in preparation for providing that support to people. We have money for substance use residential beds and no providers who will provide those services. So we're hoping some of our providers will expand because the main problem is that we need the higher acuity beds. And there are no providers that are willing to do what it takes to become a provider at that level. So we are a little frustrated in Sacramento County in trying to provide those higher levels of care. Our budget for 25-26 includes a budget for a second behavioral health urgent care center, which we're really thrilled about, 24-hour behavioral health urgent care center. We are building a mental health rehab center. I'm not sure of the number of beds, but that's a badly needed subacute care in our community. We're very low on subacute beds. We have many acute care beds. We have 4 private psychiatric hospitals in Sacramento, but we have very, very few subacute beds. And we are building a new acute care facility for youth and children that will be county operated. And that is in part stimulated by the need to provide better services to our foster youth population. We've had you may or may not have heard the story about how Sacramento County foster youth that were difficult to place were being housed in a youth detention center that had been modified mildly to provide them with a place to live. And there was a lot of consternation and uproar over that when it was made public. So they have been scrambling to revamp the programs that are offering services to that particular population of foster youth, and have developed some programs with assistance from the state to try and support foster care families more effectively in providing care to these really high acuity kids, and doing some funding things differently than they were, and combining funding from child welfare and behavioral health in order to help fund some of those particular initiatives. So we have, I think, are making good strides towards resolving some of those concerns with our foster youth in our county.
Yes, this is Bill Stewart from San Diego County, and I wanted to share an issue that's been ongoing, a concern for our Behavioral Health Board, Advisory Board. So we have been a Behavioral Health Advisory Board for 14 years. So the transition, there's we have to remind ourselves constantly about the focus on SUD because mental health is, the county focuses on it, everyone focuses on it, but to keep that balance and understand a great need is to be had there. So I just wanted to point that out because that's an issue we constantly battle about and keep our mind on and focus on because it's so easy to just kind of go with the flow with mental health. And it's called a behavioral health board, but we have to remind ourselves to make it a behavioral health board. Yeah, so I just wanted to throw that out there because I talked to other boards members from different counties and they asked about the transition to becoming a behavioral health board because they have two different boards combining. And I always mention to them the struggle we have in San Diego to consistently stay balanced and not consistently stay balanced, to get balanced and focus on SUD as much as possible.
Maybe we can go online or go ahead.
Yeah, is there somebody online that wants to
Yes, we
speak?
have three.
Oh, okay, well, why don't you do that and then we'll come back to me because I wanted to speak to the sheriff's update on the sheriff's issue.
Good. Sylvia, online?
Yes, so I was listening to all these like great ideas about what some of you do. As you know, like recently there was I guess a shake up on the boards, or there was a lot of because of the new rules about not being able to work for a nonprofit or contract with the county. Lots of seats became available. So in a good way, that's like we're kind of starting over with trying to get new people. And I think it can help shape what for some of with a lot of new people, like what we want the board to look like. I guess my question is like, I just feel so disconnected from what everybody else is doing. Like I just got not promoted, but I'm now the secretary. And I'm just wanted, I go on every other your all's county websites on your behavioral health boards and like snoop and try to see what everyone's doing, but there's not that much information. And so I was wondering if there was a way that because you guys had so much good things like about the monthly newsletters and sending that out. How do we like kind of put all these best practices that everyone's doing so that we can kind of see how's other counties are like, how are they carrying out their secretary duties and things like that? So yeah, it's just a very like broad question, but like I said, I just feel like just this disconnection between a behavioral health boards and not really knowing like how everyone else is doing it out there.
Yeah. I'm happy to follow up with you on that. What I try to do is just continually update our website with resources and provide resources just on the website as well as in the best practices manual. And a lot of that was built because of what we received from boards and commissions. So yeah, when you have specific questions, you're welcome to email or call us and we can help direct you, or we can create the materials if we need to.
Do you have to go through your chair for that, or can the board members what's the etiquette?
Yeah, we prefer that you come, either email me or call. Either way is fine.
Okay, thank you.
I just wanted to respond. This is Stacy from LA County. I would love to invite you to attend our meetings. You don't have to attend in person. We have hybrid meetings and I'm often on your meeting, for example, and also on Orange counties. So that's one of the ways that I find out and snoop and see what other people are doing. So.
Okay, thank you. I didn't know that was allowed. So, okay, thanks.
Right, yeah, we have a listing on our website of when all of the boards and commissions meet, and Manuel has been continually updating it so that you can go to the virtual meetings. You can see which ones, do virtual, and you can connect if you want. Linda?
Hi, I'm Linda from Orange County, and Steve's in the room too, so he may want to pipe in on this. But we have an executive committee meeting scheduled for Wednesday, and it's to look at our whole subcommittee process for the board. And I chair the Children's Committee, and I'm a little confused about the appropriate structure. I think I understand ad hoc committees very well, but I don't think I understand standing committee meetings of the Behavioral Health Board, of which we have 4. So my question to you, Teresa, is there are no membership lists. We do have a committee chairman for each of the board committees. We do have posted agendas, but in 2 of the meetings, the chairs participate in Zoom. And because we have no membership lists, it's just whoever Zooms in, because typically the only people who show up in person might be the chair and county people. I don't know if we're out of compliance.
Okay. If it's only one member that shows up, it's not considered a standing committee in terms of the Brown Act. But maybe your bylaws consider the Children's Committee to be a standing committee.
It does.
It does. Okay. In that case, it needs to abide by the Brown Act. So anything that you've done for your commission, like posting your agenda 72 hours in advance, not having serial meetings with yourself. I don't know. But if it's a regular meeting and it's in your bylaws, then you should, it needs to be posted. I would take it out of the bylaws personally. I think it's not really a meeting if it's just you. It might be a meeting, but it's not a Brown Act. It doesn't need to be a Brown Act meeting.
Can you have a children's committee that I chair? And Steve, it is in the bylaws, right? And
let's get some comments. We have people in the room that want to comment besides Steve. We'll start with him.
Well, I was just going to say, hi, Linda. We follow all the Brown Act. The intention was that all of our committees would be Brown Act committees rather than trying to hide them in ad hocs. Our issue, I think one of the issues is, does the chair actually have to show up in person when we're doing no voting? I think that's one consideration because everyone else could be on Zoom. And the second consideration is we have no control over our e-list. So we have a very difficult time in promoting to the community. And so we're having trouble attracting the community. And so we've been using the meetings, but a lot of the meetings, I won't say all of them, but I've been more like trying to get work groups together where we just have a chance to put the staff and community and us in a room to talk about stuff. And then we can accomplish a lot when we can talk to each other. And there's not that many opportunities where we just talk. So a lot of times it's a meeting, presentation, whatever. So I'm not sure if that, did I add the one thing correctly that about the person having to be in person, the chair having to be in person versus doing the whole thing on Zoom?
And do you have to have a list of members? We have no committee, really. We just have a chairman.
Right. Yeah. I think we're trying to build, we just haven't been able to do it.
Right. So with the larger counties, and you're in a large county, Orange County, what we've seen is there are other committees that are not, they're not standing committees of your commission, but they can help advise your commission. And this might be a good role for this committee, is that you would just allow, if staff's willing to continue on with these meetings, it sounds like they're facilitating them anyway. That it could be just, their committee. It doesn't have to, abide by the Brown Act if they're going to continue with that. But if you want it to be your committee, and it's a committee of your Orange County Behavioral Health Advisory Board, it has to, and it's ongoing. You need to post it. You need to have the agenda done. You need to abide by Brown Act rules, have public comment, and you can't, if you're going to participate, you can't do it by teleconference unless you provide your address and allow the public to come to wherever you are and post it on the outside of whatever building that is. So yeah, in this circumstance, since it sounds like functionally, that's not how this has been running. If the staff really wants to continue it, it seems like, and you want it to continue, it seems like it could continue without being a Brown Act committee.
So by removing them, if they are in the bylaws, that eliminates them from the Brown Act requirements.
Yeah, that makes it more clear if it's not in there. But if you want to continue with it, if you want to have Brown Act meetings, you don't have to have them every month. You could have them like twice a year that are run by you all. It doesn't have to be, it could be still in your bylaws and you just meet twice a year.
They're run by the staff.
You really might want to talk to your county council about these questions. We are closely supervised by our county council, who has some very firm ideas about committees. We are required to meet in person. We are not allowed to have anyone on our committees attend by Zoom. Or if they attend by Zoom, they have to be treated as a member of the public and they cannot comment or vote. And if we do not have quorum, we are not allowed to have a meeting. And if it's named in the bylaws, the standing committee, and it has to run by Brown Act rules. And the only ad hoc committees can step around the Brown Act rules, and ad hoc committees by definition are short-term, devised for a specific purpose. So our county council really rides close herd on us. If yours isn't doing that for you, you might want to get them on board, because if you start doing stuff that's not Brown Act and somebody makes a complaint, you're going to not be happy with the results.
Is this regarding that?
Yeah. This is JD Hatch from Chair for Solano County. I just don't understand why y'all still having Zoom meetings, and this is not a COVID or anything like this, or why is it still meetings being held online? We do everything in person in Solano County. Well, we do all ours in person, so we don't have no meetings. Like I say, it's not COVID no more, so we don't do anything online no more. We in person. So I don't understand why y'all still doing.
It's permissible. Yeah. There's some rules that you have to follow, but you can. Before COVID and now after COVID, they were in the Brown Act that you could teleconference, and now there's even more allowances. It's complicated though, so some counties have chosen not to provide that.
Okay, thank you.
Yeah, and we get from 80 to 110 people online, stakeholders just watching.
Right, yeah, the public likes it.
No, I didn't really want to belabor the topic. Our county council is sort of involved just because all of our bylaws are the same templates. We've had meetings with them in the past. I think I went to the Sacramento meeting when that lawyer of yours is very, but anyway, I think we're all okay. We just want to make it so we like doing the Zoom because we want the public. We have a separate issue where the community doesn't really want to participate because there's not enough safety in the room. They don't say stuff. And until we get our board of supervisors attending our meetings, we really won't get to the real issues, so.
Someone still with their
Okay,
hands up.
Mark Donegan?
Yeah, hi. Sorry about that. The discussion had me running all over my notes. I love the stuff about county council. Yeah, everything should be run through county council. Anybody has a question about that? Because, yeah, you will run into problems with the Brown Act for sure. My question is about CIT training. It was something that I talked about with our board. Well, I asked about, and I kind of met a little resistance actually from our director. I'm curious about that. But I'm wondering if the state can offer her any assistance, because I already messaged her what was given to me about the peer support training. I know that's not CIT, but it's similar. So when I messaged her, I mentioned that the CIT, I was going to bring that forward and ask for help, just to put a little burner under her that I had forwarded to you, Teresa.
Okay, yeah, I can follow up with you on ways to move forward with that issue. And, you know, I'm going to always be directing you to executive committee to determine, you know, what kind of tools you would use when you're approaching a topic, either the peer support training or the CIT training. So yeah, I'm glad to follow up with you on that.
Okay, thank you.
Is there any other issue? Yes, sorry.
So at the last quarterly meeting, we had a lively discussion about the difficulties many of us are running into in our counties of getting law enforcement to respond to mental health calls and to 5150 people, or to transport people who are involuntary. That would require a hands-on approach to transferring them to a hospital. Our county, in case you don't know it, our Sheriff Cooper, stopped completely responding to all behavioral health calls in January. They are not backing up the fire department. They are not backing up our crisis response teams, and they are not intervening in suicides in progress when requested by 988. They have done this. The sheriff has attributed his decision to a Ninth Circuit Court of Appeals case, Scott versus Smith, from last year, that found that 2 officers who used deadly force on a mental health call had lost their right to immunity because of their actions. And so Sheriff Cooper, despite the fact that there are a number of legal opinions out there saying that this is not a correct interpretation of the ruling, has chosen to interpret that ruling to say that his officers have no immunity if they use hands-on in a mental health call. So apparently we can't trust any of our officers to use appropriate force or good judgment. He has disbanded all the co-responder teams that we had. So there is no one responding, and they will only respond to mental health calls if there is a crime in progress that involves deadly force, and that is not happening inside a home. Because if it's inside a home, it's not a crime to have a weapon inside your home. And the only result will be that they will take the person to jail, not to the hospital, where they will become another felony incompetent to stand trial. So our fire department, the sheriff announced this, didn't even really announce it. They just started doing it. They just stopped responding to calls. And then 2 weeks later, he said, oh yeah, by the way, we're not going to respond to any calls. Said, you know, the law says that they may do this. They don't have to do this, so they're not going to do this. And he said that they would respond when there was a criminal act, but they are in fact not responding most of the time when there's a criminal act. We've had 3 deaths in the county in the last 3 months that can be directly or indirectly attributed to the sheriff's new policy of young adults who were in a mental health crisis. The fire department is tracking the numbers of their calls that they are going on that are mental health calls where they ask for sheriff's support and recording their response, because occasionally the sheriff's office will back them up, but the bulk of the calls that they request for backup are not getting support. So they are tracking numbers, and 988 tracks its numbers as a regular course of business. So the sheriff, I understand that NAMI California has been in some dialogue with the sheriff around possible legislation that would make the sheriff feel like he would change his policy. I feel very leery of any such legislation, giving our police officers carte blanche to use any level of force they felt was appropriate. There is a footnote in the ruling that offers, a different interpretation that does not support the sheriff's interpretation. But one of the footnotes does is offer that if a police officer is directed by a professional, a mental health professional or a medical professional, that they would regain immunity under those circumstances because they would not be in charge. That other professional would be in charge, which leads us right back to co-responder teams and coordinated efforts between police departments and civilian crisis response teams. But our sheriff is not willing to do that kind of work. He's not willing to train his officers more than the minimum amount of training. And fortunately, we have other law enforcement agencies in our county, other jurisdictions. None of them have taken the position that the sheriff has taken. However, many of them are taking a very hands-off approach where they will respond to the call, but then refuse to intervene in the call. We have been able, this has stimulated within our county some memorandums of understanding between a couple of the smaller police departments and the county civilian crisis response team. It's the CWRT. We've had some memorandums of understanding happening finally with them to get their police officers to work with our crisis response teams. That was not happening before. That's helped a little bit, but not a lot yet. This has, when they first started this policy, 911 was simply telling people to hang up and call 988. Now the 911 dispatchers are actually transferring calls to 988. They're transferring all calls to 988 unless there is a crime in progress that fits their definitions. And then it goes to a sergeant who who talks to the person who's calling in, or follows up with a call to the person who called in to inquire about details about the situation. We had a family whose daughter has threatened them with a knife, was chasing them around the house. They locked themselves in the room. She was pounding on the door with the knife, and the sheriff refused to respond. So this is happening in other parts of the state. The city of Fremont has taken the same position. The county has civilian crisis response teams. They are refusing to go to the city of Fremont for any calls of any kind because they cannot count on the police department there to back them up. So they have simply stopped serving the city of Fremont. I understand Del Norte County's sheriff has also taken the same position. And there is an effort being made through the Grave Disability Work Group and through NAMI to reach out to all the counties in the state and find out, you know, what's happening on the ground, where there are people who are responding, like in LA, where they talked this morning at the Planning Council about how they had a good relationship with their law enforcement agencies and that they were, you know, getting support from them, and compared to other counties like ours where there is very poor support or no support. So I'm happy to answer questions if somebody has questions. I think that's a pretty complete recap of the situation. It's the sheriff is an elected official. We don't have any power over him and his decisions, except the power of the purse that the Board of Supervisors has in a small amount, not a lot, to manage, you know, as a response to this unilateral change in policy.
We have a hand raised in the room. Yes, yeah. Introduce yourself.
Janet Frank, Commission on Aging. So obviously this is a very complex thing that you've been in the middle of for a long time. But I would definitely try to talk to your Board of Supervisors to find out whether they're aware of this, whether there's, okay, and they're very upset. And so they're not delivering services that they used to get paid to do. So they should definitely have their budget cut. And, you know, other things like that, that can try to get people's attention, letters to the editor, Sacramento Bee, etc. Okay.
Oh, nobody can hear you online without a mic.
So, just a couple comments. I think you hit the nail on the head when you said the sheriff's department, because the sheriff is an elected official, they can pretty much do what they want. So, I mean, and they call the shots. You know, this is kind of one of those stickier situations. You said you have a good county council that reviews a lot of what you do. There's actually where you need the legal advice on there. County council needs to provide what direction they need to go to. I can see the sheriff's point in terms of liability and so forth. He's not going to extend himself, but you know, to kind of turn this issue in a different way. There's a lot of people that are critical about law enforcement responding to strictly mental health calls like that. In fact, I think in a pure world, you know, it would be the calling from a lot of people that say they don't need to be there. They shouldn't be there. So, I mean, in a sense, what's happening in your county might be the utopia of where we're heading in the situation. But I feel for you, it's a transition. I think that the courts are going to have to play out on this, and the liability is a big issue, you know.
So our county council for the county issued a different legal opinion than the sheriff is following. The county council said that the sheriff's interpretation of the ruling was incorrect, and that it was a misinterpretation of the ruling, and the sheriff basically said he didn't care, that he was going to do what he was going to do. And the Board of Supervisors, and you know, we were being told for the first 3 months that, you know, there was dialogue happening behind the scenes. Nothing has changed. It's been 6 months now. And so the sheriff has made it really clear. And I did not mean to imply that I thought the best person to respond to a mental health call was a police officer. But there are times, not a lot of times, but there are times when a first responder is what you need. And when the sheriff won't back up the fire department, the crisis response team, or 988, I have a problem with that, because those are professionals on the front lines who I think have the right to expect the sheriff's department to back them up when they get into a situation that's dangerous. And there is no one else who is trained, qualified, or legally allowed to do the things that the sheriff does in those situations. We cannot make our civilian crisis response team first responders. The law lays out in statute who it qualifies as a first responder. So even if we wanted to, we can't give them lights and sirens so that they can go and intervene in a suicide in progress. We have to have the sheriff, we have to have law enforcement there a small number of times. Based on the information I have from the sheriff's department and the community wellness response team and 988, we're talking somewhere between 40 and 80 calls a month that other responders are not getting backed up on, where people are going unanswered. They're calling 911 for help and no one is responding.
We've got somebody online, Sylvia with her hand up.
Oh, yes. I was just, I'm so sorry that that's happening too. I wasn't aware, that was happening in Sacramento. I just feel very blessed that I live in Camarillo and, in Ventura County, where 98% of our, I think it's 95% of our officers are SCIT and are very involved in our mental health and try their best to respond to every mental health call that they can, and sometimes they get it wrong. I hope that we can like support you in any way, trying to come up with ways. I mean, I don't know how long he's got in there. Is it a four-year term? So it's now trying to figure out how to get somebody else in there. But yeah, my heart goes out to you and your county. I'm so sorry.
This is Steve McNally in Orange County. So in the Cal Matters article, our sheriff was quoted as well. That, I mean, he does it, but they don't want to do it. But our issue is a little bit different. Once we got the state mobile crisis response money, 85–90% of our calls now have no police involvement. Before, 100% had police involvement. And that was guys in uniform, not in different clothes, not with the gun hidden, not the police down the street in case something was needed. And SAMHSA with crisis response is like 3% require police involvement. But this in not transferring people on holds for the people that weren't here earlier this week, that so far is about 140 people in our county because they're tracking it. And so I was thinking that I would go to Sheriff Brown on the OAC, who I think is a Santa Barbara sheriff. I would go to the Sheriff's Association. What was that? Well, I'm sure everybody will be on law enforcement, but it's not a matter of making them do it. I just want to know who's going to pay when sued. In our county, 4 people and 2 lawyers plus Catholic worker, and 2 lawyers are relatively unknown, met the right federal judge that forced the county to put in tons of shelters. So if you have people that are being harmed, there might be an approach, if you find a lawyer who cares about mental health, to see if that's worth doing. It's the shame and blame. You don't want to play the game, but he's not going to do it on his own, it doesn't sound like, until something bad happens and he pays out for that. So yeah, I'm not.
Anybody else? All right. Well, I think we reached the end of our session. We made it to the end of the agenda anyway. So lots of work to do. Thank you to everybody who serves on one of the 59 local behavioral health boards and commissions. And thank you to staff as well. And thank you to all of our external partners that have sat in on the meeting today too. Don't hesitate to contact us. Oh, and we have an announcement.
It's just for the room.
Oh, okay. So we'll go ahead and end the teleconference portion, and then those in the room stay for just a moment, and Christine has some information for you. Thanks, everybody. Everybody take care. Bye-bye.
Bye. Thank you.
So the association